We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Amogs Emergency Obstetrics Committee with Indore, Jabalpur Societies of Ampogs. And today's episode is 49. So it's my pleasure to introduce the convener of today's webinar, Dr. Paula ma'am. Ma'am is consultant reproductive medicine and surgery, Nova IVF Center, Raipur, ex-consultant of reproductive medicine, Diva Fertility Center, Nagpur. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. So, I would like to invite Dr. Deepti Gupta, ma'am, the convener of this session. She is a secretary of All MP Obstetrics and Gynec Society. She is also the managing committee member of MP ISAR. She is a West Zone coordinator of Foxy Quiz Committee. She has multiple awards to her credit. I welcome you, ma'am.
Thank you, dear Polumi.
Next, I would like to invite our coordinator, Dr. Shweta Kaur Jha, ma'am, who is the Vice President of Indore Obstetrics and Gynec Society. She is the Director of Niramay Care Women's Center, Indore. She is Vice President, Indore Obstetrics and Gynec Society, Managing Committee member of ISAR, Joint Librarian to MP ISAR. She also has multiple awards to her credit. I welcome you, ma'am.
Thank you, Polumi.
So, moving towards the next session.
Yeah. Should I go ahead?
Yeah, please.
So at the outset, good evening to everyone. It is an honor and privilege to be sharing this esteemed platform with so many my own teachers and so many esteemed seniors. And it is really a very happy moment. And it is an honor and privilege. I'm extremely grateful, Sneha ma'am, for giving me this opportunity. And just to complete the formalities, I would like to give a formal introduction of Sneha Bhuyar ma'am. Sneha Bhuyar ma'am, who's done her MBBS and MD both from Pune, is managing director. And as you can see, she has 32 years of experience in the field with so many years of teaching in Yavatmal. She is also contesting for the post of vice president from West Zone elections in August. Numerous talks and publications to her credit, multiple awards and accolades. But above everything, I think all of us have known Sneha ma'am as a very, very humble, hardworking, approachable, and a very, very sincere human being. And it has been an honor to know you, ma'am, and your consistency and your passion is really commendable. So we welcome you formally on behalf of the Emergency Obstetrics Committee, Amogs, and my greetings and regards to all Amogs office bearers and all my seniors and friends from MP OBGY Society. I would like to save the precious time for academic discussion.
Yes. Thank you so much, Dr. Dipti. A very good evening to one and all. My respect and regards to all the seniors here. At the outset, I would like to thank and welcome both the organization Amogs as well as Ampogs. I would like to welcome our Amogs President, Dr. Kiran Kurtakuti, the Ampogs President, Dr. Kavita Singh Madam, and of course, Madam Jyoti Binda, who is the past President of Ampogs, as chief guest for today's program. And the three Bs from Indore, actually, Dr. Ashli Bakshi is down with viral fever, so she will not be joining. Dr. Kavita Bapat has some family mishap, so she will not be joining. And Dr. Archana Basai is going to join soon. So I just welcome all of them. And I welcome the speaker and of course the President Indore Society, Professor Dr. Sumitra Yadav, Secretary Dr. Sunita Chauhan, and Jabalpur President and Secretary Dr. Rakhi Bajpai and Dr. Abha Jain. So all of you, I welcome once again all the chairpersons, panelists, experts for this program. And I take this opportunity to have words of wisdom from President Amogs, Dr. Kiran Kurtakoti. So without wasting time in the introduction, I would just request Dr. Kiran to guide us. Yeah, over to you, Doctor.
Thank you, Dr. Sneha. Well, today is my co-chief guest, Dr. Kavita ji, Dr. Jyoti Bindal, another the fourth big B from Madhya Pradesh. So, Namaste Jyoti ji, and to everyone. Regards to Dr. Sumitra Madam, of course, Dr. Shweta, Dr. Anuradha, Dr. Rakhi, Alka, and hi to Dipti and to Dr. Shweta and Dr. Paulami. So, thank you. First of all, Sneha, what can I say about you? Doing so many webinars day on and day out, and teaching so many people, because of all these webinars, जैसे all these topics have become by heart to me, at least by now, because I have attended so many webinars and talks and different people. I'm really keen to listen to the today's speakers. Dr. Subhitra Madam, of course, we have met prior to many conferences in Mumbai, and of course, Neha, you'll be talking on near-miss cases, and really love to hear all of you. Dr. Jyoti, you have been to Pune many times, and really a fine thing to listen to you also. So, Sneha, best wishes to you, best wishes to Dr. Shweta, best wishes to Dipti, and everyone who is trying to achieve some kind of position somewhere. So best wishes from Amogs side. Amogs is always with all of you guys. And Kavita ji, always thank you for associating Ampogs with Amogs. So thank you all for that. And Sneha, please get on with the program. My best wishes to all of you.
Thank you so much, Kiran, for being so short and so precise. But yes, your message is well conveyed. So, Dr. Dipti, I would request you to introduce and invite Madam Kavita Singh for her precious words.
Yes, ma'am. Thank you so much,
दीप्ति
ma'am.
कुछ पढ़ना
And
मत ज्यादा
जी
कुछ
मैम,
पढ़ना मत
मैम
सीधी
बस
स्लाइड से कुछ मत पढ़ो हाँ
मेरे ग्रीटिंग्स एंड रिगार्ड्स टू माय टीचर्स बिंदल मैम, कविता सिंह मैम। मतलब आज भी हम हर ड्यूटी में, हर क्लिनिक में हमेशा याद रखते हैं। और सिंह मैम इज करेंटली डीन जीएमसी and chairperson of Ampogs, President Ampogs and State Chapter Agoin as well. And we know कि कितने भी एडमिनिस्ट्रेटिव काम आए जाएं, लेकिन हर कनेक्ट विद एकेडमिक्स एंड सर्जरी कभी फेड नहीं होता है। Along with her optimism, positivity, seeing opportunity in every challenge, and on and on and on. So, ma'am, we would like to hear you.
Thank you so much. Thank you so very much, Deepti. And at the outset, I would like to thank Sneha and Dr. Kiran for giving me opportunity to meet my wonderful Ampoxians online. And I'm so happy to see Madam Jyoti Bindal. अगर आपको बिग भी बोलना है तो मैडम को ही बोलना है, मुझे नहीं बोलना है. So, all regards to Madam Jyoti, and it's so wonderful to see Shweta, my friends Sumitra, dear Anuradha, Roma, and I can see Dr. Alka, Are Jare, बीच में Rakhi Bajpai and Shazi and all the friends across the state. तो सबको मेरा बहुत सारा नमस्कार. और जैसे स्नेहा ने कहा है, हमको टाइम नहीं वेस्ट करने का है किसी भी इंट्रोडक्शन में और बातों में, पढ़ाई करना है. तो स्नेहा, बिल्कुल तुम्हारी बात पे नमस्ते दीदी, आपको भी आप भी आ गए. बसेर मैम, तो नमस्ते सभी को. और आई एम सो हैप्पी. एंड दीप्ति, तुम जो सब ऐसे बोल देती हो ना, एकेडमिक्स, ओपीडी, सर्जरी, तो मतलब मैं मतलब सच में बताती हूँ, आई रीच बैक टू माय ओपीडी ओटी देयर. Though I am able to manage my passion here also, I'm taking classes, I'm seeing patient, I am operating as well in between administrative hip hop at Bhopal. So all my best wishes to Sneha for her and Shweta for your future endeavors, and all your my best wishes from Ampogs. So thank you so much, and best wishes for, because the topics are already covered. We are looking forward to listen to wonderful speakers. Thank you so much. Regards.
Thank you, madam. Thank you for your precious words. And now we would like to go ahead and request Shweta to introduce Madam Jyoti Bindal.
It is my proud pleasure to introduce my teacher and somebody whom I have been following since childhood. She is at present Vice Chancellor of Sri Aurobindo University.
Got muted, Shweta. Got muted. Please unmute yourself.
Hello, she is Vice Chancellor of Aurobindo University and she is a recipient of J.G. Jolly
बेटा
Original
स्किप
Award.
करेंगे इसको.
Madam, just few lines. Foxy Shiromani Award, and she is member of state PCPNDT, and she is ex-dean and CEO of MGM College Indore, ex-director Gwalior, and ex-dean and CEO of Government Medical College Shivpuri, and she is teacher of teachers. Of all the people here sitting in this screen, all of us are students of Dr. Jyoti Bindal, madam. So, madam, the podium goes to you for your blessings.
Thank
Welcome,
you
madam.
so much, Shweta. That was a little humbling, but I'm so thankful to Sneha. She brought me on this platform to share with Kavita and with Kiran. Both have been my longtime colleagues. I can see Archana Basir. I'm not going to name everybody, but Deepti, yeah, every time I see you, I feel proud of my PG. So again, thank you so much for having me. And मैं इफ किरण इज हियर मैं एक बहुत इंटरेस्टिंग इंसिडेंट सुनाती हूँ एंड इट्स नॉन एकेडमिक. किरण, जब फर्स्ट टाइम आई कॉल्ड हिम टू ग्वालियर, सो ही हैड अ वंडरफुल वे ऑफ प्रेजेंटेशन. और मेरे दिमाग में आज भी किरण का एसोसिएशन उस स्लाइड से है. एक देयर इज अ पूल, बाढ़ आई हुई है. सो इन अमंग्स दैट फ्लड एक कुर्सी रखी है और एक बार एक आदमी के बाल काट रहा है और caption है bindas. So what he was saying is that don't be bindas when you are in a OT. कुछ I think it was something like MTP perforation of uterus या ऐसा कोई slide था. Oh my God! Every time I look at Kiran, I remember that slide. So such an impactful presentation he always does. So yeah, it's great to be with you. Sneha, very happy that you chose these two topics, thromboprophylaxis in pregnancy and near miss cases. So, and I have to comment that you brought all of us together for these because इन टॉपिक्स को हम टेलर मेड नहीं कर सकते. वी नीड टू बी स्पेशली make them evidence based, risk stratified, and that is how we need to deal with these topics. And probably the timely intervention, especially in thromboprophylaxis, can make the difference between life and death, especially in those high risk pregnancy. And coming to the near miss cases, yes, they are the window into which we can see what can go wrong. That's the whole thing. What can go wrong, anticipation, prevention, and rapid response. So these are the key areas. And recently we did a seminar on webinar on pumping of adrenaline. I think Archana Basir is here. She was the one who organized, and we really talked of how all of us have adrenaline pumping in the labor room. So once again, near miss cases are the ones which make every gynecologist nearing a heart attack. Yes. So thank you so much for having me here, and let's move on to the academics. Thank you.
Thank you, madam. Thank you so much. In fact, I would share with you that the original name for this panel discussion is adrenal surge for the obstetrician. So that is how, we are trying to cover the SAMM or the near miss cases. And thank you so much for all your blessings and love. We would like to move ahead and go with the, blessings and guidance from Dr. Archana Basse, who is the past vice president of FOXI, all of you know. So without much ado, I think we are eager to listen to you, Dr. Archana. Over to you for your precious words.
Dipti, can you share the delegate link? I can pass it on to my students. Please share
Yes,
delegate
ma'am.
link with me.
Yes, ma'am.
Thank you. Thank you.
Hi, Sneha. Thank you so much for having me here. And really, I'm happy to share dais with Dr. Kavita Singh and our dear Dr. Jyoti Bindal and all the our faculties from MP and other states. I think the topic which you have chosen is very great. Dr. Jyoti and Dr. Kavita has already stressed upon the adrenaline rush. I will not take much of your time. I want to wish you all the best in your future endeavor and Shweta also in her future endeavors. May you do well, and we are all eager to listen to the adrenaline rush. So thank you very much and all the best.
Thank you so much. Thank you so much. So with this, with God's blessings and the blessings of respected seniors and our guests for today's program, we thank everybody, for gracing this program. And of course, we would move ahead with the academic session. And I hand over the dice to Dr. Paulami for the academic session. Let us move ahead. Dr. Paulami, you can go ahead with the introduction of the chairpersons.
Thank you, ma'am. So moving towards our first session of the evening, the topic is tackling hyperglycemia in pregnancy. So I would like to invite our first chairperson, Dr. Rakhi Bajpai, ma'am. She is the president of Jabalpur Obstetrics and Gynec Society. She is a chief fertility specialist and gynecologic laparoscopic surgeon in Sai Test Tube Baby and Laparoscopy Center, Jabalpur, MP. She has many awards to her credit. I welcome you, ma'am. Now I would like to invite our next chairperson, Dr. Sunita Chauhan, ma'am. She is the secretary of Indore Obstetrics and Gynec Society. She is the head of Department of Obs and Gynae at Kokilaben Dhirubhai Ambani Hospital, Indore. She is the executive member of MP IAG. We welcome you, ma'am.
Thank you. Thank you.
Now I would like to request our chairpersons to introduce our speaker.
Hello. Good evening, everyone. Myself, Dr. Rakhi Bajpai, and it's my pride and pleasure to introduce Dr. Professor Sumitra Yadav, madam. She is MBBS, MS, DNB, MS, Professor and Head, Obstetric and Gynecology Department, MGM Medical College and MTH Hospital. She has a teaching experience of 33 years and she has received many awards. HIV Utkarsh Seva Award 2007, 2008, 9, 11 and 12. Nari Shakti Award by Braj Bhumi Foundation of Hema Malini on September 13, 2019. Nai Dunia Naika Award on Distinguished Social Service in 2012. Nai Dunia Award for Utkarsh Chikitsa Sahyog, winner of CS Dawn Award twice for Best Paper Presentation on Maternal Care in 2001 and 2008. And she has also received Young Scientist Award in 2000. She has so many other feathers on her cap, and I would like to invite her for her talk on tackling hyperglycemia in pregnancy.
Good evening, everybody. At the outset, I would like to thank the chairpersons, Dr. Rakhi Bajpai, for the kind words of introduction. At this moment, I would like to thank Dr. Sneha Bhuyer for giving me this opportunity to speak before both Amogs and Ampogs. Both are almost my family, one from the Maika and the other from the Sasural. So it's great to be here. And my good wishes are with Dr. Sneha for her venture to the post of VP. Can I have my slides, please, that have been provided by
Thank
Dr.
you so
Bhim?
much. Thank you so much.
All the best for your elections, ma'am. You will have a good time.
Thank you,
Uh,
madam. Thank you so
And my
much.
very best wishes to you and to Shweta, both of you.
Ma'am, with whom you have shared the slides, ma'am?
Doctor, they are Madam Boyers. My topic is hyperglycemia in pregnancy.
Okay, I'll share.
Thank you, ma'am.
So hyperglycemia, it is very easy to think about hyperglycemia, but the question is that we are noticing that this is increasing. And why is it increasing? Because we know that our habits have become comparatively much sedentary as compared to the previous generations. Our eating habits have changed. We are not eating the kind of food that they were eating. It is more refined in nature, and therefore this is leading to many other disorders apart from not only gestational diabetes but other things. So now we have divided that hyperglycemia or glucose intolerance into the variable degrees recognized during the first time during pregnancy. Compared to West, in India, our incidence is much higher. Next slide, please. So now we realize that 1 out of 6 live births is occurring into women who have some form of hyperglycemia. It is not as a clear, crystal clear picture that, okay, this is a patient of diabetes mellitus in pregnancy or it is GDM. There are gray zones in between. So that also we must know. And we must understand this is a very important slide for you to note. Now, blood sugar levels and perinatal mortality, are they linked to each other? Yes, they are indirectly linked to each other in a inverse proportion. If the blood sugar level is around 100, the perinatal mortality is 4%. Around 150 to 200, it is 16%. So there is a fourfold increase in the perinatal mortality if the sugar rises by just 1.5 to 2 times. If it is more than 200%, it straight away jumps to 35%. So you realize that this is a very important intervention where what we can do to save the neonate. So it is important that we have a very strict blood sugar control, and this can be achieved. You don't need to go to a diabetologist or anything, but you should target your blood sugar levels and arrange your nutritionist and your exercise, and that can be done. Next, please. Now, we know that the diabetic population is growing. But what we should target is that not to be diabetic or not to be pre-diabetic. Now, there are 3 forms of diabetes. One is diabetes type 1, diabetes type 2, GDM, and also MODI that I'm seeing quite commonly nowadays. So, this third type is also insulin dependent, and we should be also thinking about that fourth category. Now, we know that 60 million women of the reproductive age group worldwide have diabetes, and India is the potential, you can say, focus of diabetes in the world. So when India has so many diabetes men and women normally, the percentage of women having gestational diabetes is also increased. And we know that in any subset of pregnancy, 40% to 50% pregnancies are unplanned. So if why are we so much worried about hyperglycemia? I've already told you hyperglycemia is directly proportional to the perinatal mortality. And how it affects the perinatal mortality? Because the fetus, there can be spontaneous abortions, intrauterine death, growth issues, anomalies like cardiac, skeletal, then a shoulder dystocia because of the macrosomia, and because of that, birth trauma, fetal distress. And when you have to deliver a macrosomic baby, you will have to have instrumental delivery. Once you have the instrumental delivery and there's a large baby, large fetus, polyhydramnios, there is every chance of having a PPH. Once you have PPH, the volcano of PPH starts. And then if you have a cesarean section, that will start another cascade leading to sepsis and all. With the diabetes, there is associated vasculopathies, retinopathies, nephropathies associated. So you have to actually, a mother having a simple diabetes is not that simple. It is associated with a varied cascade of things and affecting many organs. So you have to see diabetes or gestational diabetes in a whole picture, not as a patient alone. So we know that why pregnancy is diabetogenic. This is a question that we ask always the PGs, because we know that the placental hormones such as estrogen, cortisol, and HPL, all of them lead to increase in the blood sugar level. And why it is so? Because the baby should get good amount of glucose as a substrate. So that is important for the baby. So they inhibit the insulin of the mother. Next, please. Now, insulin resistance increases due to hormones of the placenta, HPL, and human placental growth hormone, progesterone, and there is increased calorie intake, reduced exercise. Now, the moment a woman becomes pregnant, they stop doing any work, not even simple work. They want to lie in the bed. That adds on to the insult. Now, why in macrosomia the babies are large in diabetes? Because they have plenty of substrate, that is the glucose, and that adds on, that goes into the extra glucose goes into the body of the baby. The baby will put on extra weight, extra fat, and therefore the baby will become, because of the overnutrition, will become macrosomic. Next, please. Now, there are many effects of the high sugar levels on the mother and the child, both. Insulin resistance has a lot of effects. We know apart from diabetes, when there is intrauterine exposure to the maternal diabetes, the baby will be large for gestational age. It will be a child with obesity, and it will have many other disorders also as a young adult, and will be prone for getting diabetes. That is also very important. Now, GDM is, we know that it is in risk screening. We know that PCOS has insulin resistance. We know obesity, there is insulin resistance. If there is a family history of diabetes, or if there is age over 35, suspect. In fact, in India, suspect for everybody. Don't leave anybody. Next. A universal GDM screening has been made mandatory in India, not only by FOXY, but also we are working in the government sector also and private. So NHM also has made it mandatory. We are provided with 75-gram glucose sachet free of cost to test this. All the Asha Anganwadi are to do it. Now, these are various guidelines that are confusing. We stick by the FOXY DIPSY guidelines of the Kolkata Declaration. That single step, 75-gram glucose is taken within 5 minutes, and then we measure the glucose levels of the mother. So 75-gram glucose challenge test is done. It is random. You don't have to be fasting before it. Yeah, and you have to test after 2 hours. If the level is more than 140, it is diagnostic of GDM. You don't have to worry much about it. These are the DIPSY guidelines, the Kolkata Declaration. Now, what is the protocol for investigation? It is to be done twice at least during the antenatal period. If the patient comes to you late, do it at the first visit as early as possible. The second testing, if you're doing first during the first trimester, the second should be at 24 to 28 weeks of pregnancy. If the first test, even if the first test is negative. And between the two tests, there should be at least a gap of 4 weeks. These are the very important points that have to be stressed. Now, this test can be conducted for all pregnant women, even if she comes late in pregnancy or during the time of first contact. If she presents beyond 28 weeks of pregnancy, only one test is enough. And if the test is positive at any point of time, the protocol of the management is to be provided as given during the guidelines that we'll be following. Now, single step, 75-gram of glucose is dissolved in 300 ml of water, and the woman has to be taking it within a period of 5 minutes. It cannot be 20 minutes or it cannot be 30 minutes. Even if she is full stomach, that is non-fasting, last meal had within 30 minutes or fasting. It is irrespective of these things. And then within 2 hours, the sugar level has to be taken. A plasma standardized glucometer should be used after the oral glucose load. And if the vomiting occurs within 30 minutes of glucose intake, the test will be repeated next day because the glucose levels will become different. If the vomiting occurs after 30 minutes of ingestion, the test can be taken, it doesn't matter. And if the plasma glucose level comes more than 140 milligram per deciliter, it is taken as that the patient is gestational diabetes. Now, there are a lot of algorithms, but if there is a woman who comes positive beyond 160 milligram per deciliter, then you have to manage her as a GDM. If she comes negative at the first test, that is less than 140, and in repeat testing she comes out to be positive, manage as GDM. If she comes out negative, manage as a normal pregnant woman. That is the simple thing that you have. It is very simple, this algorithm. Next, please. Now, if GDM has been diagnosed, now what? Now, there are different status. If it is less, just around 120, it is or less, it is normal. If it is 120 to 139, it is gestational glucose intolerance. It is not GDM, but you have to be alert here. If it is more than 140 to 199, it is GDM. I mean, and if it is 200 or beyond, it is frank diabetes. So one thing that needs to be stressed, and I should thank Dr. Bhuyer for keeping this topic, is that I have noticed that although you must take the opinion of a diabetologist, but whenever you are doing management of GDM can be managed by medical nutrition therapy. And if it is not controlled by medical nutrition therapy, then only you should go in for the control of sugars by other methods. What is medical nutrition therapy is that you have to monitor the fasting blood sugar and the postprandial blood sugar every third day and frequently, and you have to allow the woman, you have to tell her about the nutrition, what she should take and what she should not take, and she should increase her exercise. Next, please. Now, what are the management? Non-pharmacological, that is diet, exercise, and the other two things that you have on your armamentarium are insulin and oral anti-diabetic drugs like metformin. Now, what you should do, that you have to always monitor your sugar. Just don't say that I've advised my patient for the diet. They may or they may not follow the diet. So what you should be bothered about her diet is that she should get all the nutrients that are required for the mother and the baby, and she should have appropriate weight gain. If she's obese, the weight gain should be less. If she's lean, she may have some more weight gain. But you have to be very careful about her weight gain. She should not ever gain more than average weight gain. That is 11 to 12 kgs. Next, please. Now, if it has been, this nutritional intervention has been recognized as the cornerstone of therapy, as almost 30 to 90% of the women with GDM are well maintained on just nutritional therapy. And which of the patients will receive, who can receive? If the patient has been put on MNT, her HbA1c may reduce and may not require insulin therapy. So this is a very important thing, and there are less severe perinatal complications, including macrosomia and large for gestational age baby. The food plan has to be individualized and it should be culturally acceptable. You can't ask one Punjabi woman to be on idli sambar every day. She'll be having her diet. So that also should be adjusted accordingly. But you can't expect us to adjust according to pizzas and pastas. That is also very important. Now, this is the weight gain that is to be had, that you can find out from the books. And if sedentary habits or heavy work, the basic thing is that the woman should have only 300 to 350 maximum kilocalories per day. So if sedentary work, you must think of energy requirement as only 1800 plus 300 to 350. That is how we go on adding this. We have been learning since our PG days. Next, please. Very few come into the category of heavy or moderate activity. Now, if this I've already told you, the underweight and the overweight. Now, what is the carbohydrate requirement? We know that the total carbohydrate in Indian diet is very high, up to 75 to 80%. But basically, it should be between 55 to 60%. And we must restrict the carbohydrate intake to 50%. Must restrict here because carbohydrates are a source of sugars. They convert into sugars. So we must uh, avoid simple carbohydrates and switch on to complex carbohydrates. Next, please. Now, there's something known as glycemic index, and that is very important to tell the patients what to eat and what not to eat. Low GI, that is low glycemic index, are the best ones like legumes, lentils, dried beans, peas, green gram, Bengal gram. These are rich in fibers and low conversion into sugars. Medium ones are fruits and rest all like rice, white bread, root vegetables, carrot, candy bars, syrups fall into the high GI. This should be avoided at all costs. Next, please. Now, how do we modify the diet? If you see the first plate, there are at least 7 idlis placed there. That is all carbohydrates. Very little of dal in that. So ask the patient to fill half the plate with non-starchy vegetables. This is a very nice slide. And on the other half, serve palm-sized proportion of healthy protein and a fist-sized protein of starchy food. This is how you will have to explain the woman. Then she can go into the thing. This is a very dangerous slide because if you see, you'll stop eating sweets like what I would be. It will be a punishment for me. But imagine one gulab jamun has so much of calories as a bowl of Simayas. So this is what is the thing that we must understand, and this we should explain to the patient that you must stop eating these things. Now you have to choose healthy fats. We have been hearing about PUFA, MUFA, and SFA and trans fats from the past almost 20 years. It is there in the newspapers and everything. Now remember, according to the chart also, never stick to one oil. Always rotate the oils. If you're eating soybean oil, you can go on to canola oil, you can go to peanut oil, you can go to olive oil, can go to corn, sunflower, coconut oil. Some people are eating. These things are being revised day in and day out. But as a safe bet, polyunsaturated, that is the oil having different carbohydrate based oils are much better having two or more rather than monounsaturated. Rice bran is very much, and till seed, that is the sesame seed oil, has been used for over the years since generations. Next. So protein requirement, we know that additionally 23 grams of protein is required for any pregnant woman. So we know that the woman can have from vegetarian sources like soybean, paneer, and nuts, peanuts, and almonds. Not almonds essentially, but you can have from peanuts also. Hummus is a very good source. And you must add on green leafy vegetables, not for the protein part, but for the fiber part. Next. Now, this is very important. FIGO recommends that nutrition, counseling, and activity are the primary tools for the management of GDM. This is what I wanted to stress again and again, that unless and until at every visit you tell the woman what to eat and how to stick to her diet, that will lead to her blood sugars turning right, and she may not be needed to be put on any drug. Plus, not only the nutrition, plus the exercises. Next, please. Next slide, please. Now, this I've already told you that it is according to the resources, and this needs to be stressed again and again. And the woman has to be advised self-monitoring of blood sugar. She has to have a glucometer and she has to religiously monitor. What they do is fasting they might take, postprandial they'll not take at the same time. So you have to tell them that this is directly proportional to your baby's well-being. Once you'll tell that, not her own well-being, if you'll tell that the baby will not be well, then they'll report the correct figures. Next, please. Now, these are the technical and operational guidelines that the metformin or insulin therapy is the accepted medical management of pregnant women with GDM, not controlled by medical nutritional therapy. Although insulin is the first drug of choice, metformin can be considered after 20 weeks of gestation. And metformin, we have wonderful results. It is not that metformin is bad. We have seen so many patients of PCOS also being treated. Now, exercise, I was again and again telling it is that exercising for 30 to 45 minutes after meal helps to keep the blood sugar at a target range. We always tell the woman to stroll. Here, you ask her to walk a little bit faster for 20 minutes per day, gradually increasing to 45 to 60 minutes. And it is important to maintain the balance and avoid falls. If she is doing a brisk walk or doing her household work, that is equally effective, and upper arm exercise is also very important. Next, please. Now, when would you start insulin? This is a very important thing. When sugars are not controlled, when the fasting sugar is beyond 95 milligram percent, and 2 hours blood sugar is beyond 120 milligrams, you may have to require the treatment. And if it is diagnosed, it is the GDM is diagnosed if the fasting blood sugar is beyond 120, and hyperglycemia in pregnancy is diagnosed if the 2 hours glucose, postprandial glucose is roughly around 202 and beyond. Now, the important thing is in the first trimester, if the woman comes to you right in the first trimester and you've got it done, the DIPSI test, you may also get a HbA1c done to know what was her status of her sugars. If the HbA1c was very high, 9, 11, 15, you may have to think about the congenital malformations of the baby also. Remember, at every step, you have to get the retinopathy ruled out and the nephropathy ruled out. So every trimester, you have to do the fundal examination, get the fundus examination, and the serum creatinine done for these patients. Now, the dating scan is essential in these places at 11 to 13 weeks for nuchal translucency, and the double marker is to be done at 11 to 13 weeks. Though here, apart from the double marker, the nuchal scan, you have to rule out the congenital heart disease and the sacrococcygeal tumor also. Next, please. Now, during the second trimester, as I've told you, the maternal screening remains the same, but the anomaly scan, that is the target scan at 19 to 20 weeks, is essential. And if you can get the 4-chamber view with the outflow tracts for women that are pre-diabetic, it is very important. If you cannot see the echo well at 20 weeks, 18 to 20 weeks, you must get a repeat echo done at 22 to 23 weeks to know the status of the heart. During the third trimester, you have to monitor the blood sugar and also for proteinuria. That is important. You must also be screening for the fundal height for ruling out either growth restriction or for a large for gestational date baby or for a polyhydramnios or for a oligohydramnios. This is very important. And once you reach 28 weeks or 28, 32, 36 weeks, scan should be done, and it should be done frequently. You have to rule out placental insufficiency. From 32 weeks onwards, you have to get an NST, and if you are suspecting placental insufficiency, you have to get a Doppler done. And from 38 weeks onwards, in fact 36 weeks onwards, you must become alert and you must start thinking about her way of delivery. This is a very busy slide, but it is very important. It will not be able to, I'll not be able to explain it so easily. Next slide, please. Now, this was the thing that I was telling. At 38 to 39 weeks, you have to decide what to do. So you must start deciding from 36 weeks what you will be doing. By 36 weeks, 37 weeks, you start understanding whether the baby is going to engage or not. She has had a live birth, which is vaginal or not, because that will also determine your course of action. If the baby is less than 3,800 grams or is appropriate for gestational age, and if she has poor control, poor compliance, then induce the baby. If history of stillbirth. If there is none, you can continue her till 40. I wouldn't suggest going beyond 40 weeks in any case of GDM. Though it is written here, I would not advise to go beyond 39 to 40 weeks because these patients can have a sudden stillbirth at any stage. So it is better to deliver the baby. Remember, even when you are inducing the labor, remember to be very alert. These patients have a stillbirth unknown and there is no cause coming out and the patient can sue you. So this is very important. We have to understand that the patient's sugar level has to be monitored very frequently. She must be given good hydration, avoid ketoacidosis, and everything should be plotted on the partogram, and the heartbeat is to be assessed very clearly again and again. NST is to be done, CTG is to be done, and blood sugar is to be monitored every hour, and it should be below 105. And you can give only DNS and NS, not D5. And if cesarean section is planned as an elective and the patient is fasting, that dose of insulin needs to be skipped. And the dose of insulin needs to be skipped. And earlier, lot of sugars, DNS used to be given with insulin. Not necessary nowadays. It all depends on the frequent blood sugar titration. Now, the amount of insulin that is added in a 500 ml of NS depends on the sugar level of the mother. And remember, the sugar level of the mother starts from 120 to 140. That is 4 units, and the same with the urinary sugar. And then you go on increasing, adding 2 units of sugar. Next, please. Once the mother has delivered a healthy baby, the postnatal visit is equally important and she should be coming to each visit. If she doesn't come, you have to wrap her why you did not come. She has to exercise because they are also prone for venous thromboembolism. Now we'll be having a talk on that. And weight reduction is to be done. Contraception needs to be given and she has to be advised on breastfeeding that will make her sugar levels normal. This is very important and you should make the patient understand that this is important for her baby also. Now, the best contraceptive for these women is if you see copper, IUCD, if there is a vascular disease or without a vascular disease. Rest all are in 2 or 3, where 2 means where the advantages overweigh. So you can give her a implant, injection, LNG, progesterone only pill, and also combined OCP other than diabetes with vascular disease. Next, please. Now, what is the take-home message? Although I've been fast because we were late in starting, I didn't want the webinar to go late. So GDM has a profound adverse effect both on mother as well as on the fetus, and it should be prevented rather than treated. That is the most important thing. Even if it comes, you must prevent the drug treatment. Try and correct her by the nutrition and exercise. And every woman has to be screened irrespective of the risk status at first antenatal visit between or at least between 28 to 24 to 28 visit in India. Prevention should start with the use of dietary fibers and cereals, probiotics, inositols, and maintaining low BMI pre-pregnancy and avoiding excess weight gain during the first trimester especially. Treatment should be with diet and exercise only as far as possible, and drugs should only be added when you are unable to control the sugar levels by exercise and diet. Thank you very much.
Thank you, Dr. Sumitra Yadav, madam, for the excellent lecture. My teacher, my president, and my elder sister. As you rightly said, the cases of gestational diabetes are increasing day by day. So the proper diagnosis is very important. And as you said, that DIPSI is very important to diagnose the gestational diabetes mellitus, and it should be done in all the patients. Every first visit, and if it is missed in the 28 weeks or later on, and it should be identified on time to prevent complications to the mother and the fetus. And diet and exercise plays a very important role in diagnosing early gestational diabetes mellitus. And monitoring of the fetus is very important. As you said, Doppler is very important to diagnose the fetal growth retardation. And induction at 38 to 39 weeks is important. It should not be prolonged. Thank you very much, ma'am.
Thank you, Sunita. Thank you
Thank you
very
so
much.
much, Sumitra ma'am. Thank you
Yes,
so
great.
much, Sumitra ma'am.
Yes,
You have
Shakti.
given very interesting and informative talk on the topic. Madam, I am very much impressed the way you talked about the management, the judicious use of medicines,
Thank
metformin,
you, Shakti.
insulin, and the way you talked about the diet and exercise. I am very much inspired.
Thank you
Thank
very
you
much,
so much,
Dr.
ma'am.
Rakhi. Thank you.
And I would like to thank Sneha madam and
Yes.
Shilpa madam for giving me opportunity to chair this session. And I would like to give them all the best for their future endeavors.
Thank you, dear. Thank you. It's a
Thank
pleasure
you.
to have all of you here on board. I'm very happy to have all of you. And Sumitra ma'am,
Thank you,
congratulations
madam.
for presenting so well. Uh, I would just like to make one comment here that the initially it was, you know, maybe we are around the same era 35 years back when we were postgraduates. It was only risk screening, the slide which we showed, you know, the four age more than 35, obesity, family history, and PCOS. So now the trend is, or the guidelines are in favor of universal screening. That is, every woman should be screened for every pregnancy. In the message, very well delivered. Thank you so much, madam. The last
This happened in
delivery.
2010.
Yeah.
10 when Dr. Hema Divakar was the president and
Yeah.
they had got these guidelines.
Yes.
Dipsy,
Yes.
with the
Yes.
band.
Yes. Yeah. So I was a part of this study also, Dipsy. So
Yeah, very nice.
thank you. So actually, the slide which we saw for delivery, no? So it's a FIGO slide. Okay. So we have to just project.
I do understand, madam.
Hello. Yeah.
I
That we have to.
purposely told it for our Indian scenario because
Yes,
we
yes,
don't have so many
definitely.
gadgets and we don't have so much monitoring as these people have.
Yes. In fact, I would say that I also personally do not agree with that slide. One is that not to wait beyond 40 weeks. That is one. Secondly, Doppler or NST does not tell you about this unexplained stillbirth because it's a sugar level that leads to, you know, sudden unexplained that is because of the sudden hypoglycemia. That is one. And of course, even when we talk about macrosomia, they say it is more than 4.5 or 4 kg. For us, I think Indians are more than 3.5 kg or 3.8 kg at the most. So I think all of you obstetrician will agree to me. Yeah.
Thank you, Sneha madam, for giving me the opportunity to chair the session. Thank you, ma'am, and all the best to you and Shweta.
Thank you, ma'am. Thank you.
Thank you so much.
Thank you so much. Thank you so
All
much.
the best, madam.
Looking forward to have all your votes and all your society members to vote for me. I'm your own representative. Thank you.
We are with you.
And all the best for
Thank you.
elections. Thank you.
Thank you,
Thank
Sumitra,
you.
for making such a vast topic crisp and yet understandable. Thank you, our chairpersons, Dr. Rakhi Vajpayee ma'am and Dr. Sunita Chauhan ma'am, for chairing the session. So now moving on towards our next session on thromboprophylaxis on pregnancy, I would like to invite our esteemed chairpersons for the session. The first chairperson for this session is Dr. Komal Jain. She is Secretary, Jabalpur Obstetrics and Gynec Society. She is currently working as Director, KJ Memorial Hospital, Jabalpur. Her areas of interest are high-risk pregnancy, diabetes in pregnancy, and infertility. Our next chairperson for this session is Dr. Alka Agarwal, ma'am. She is the president of Jabalpur Menopause Society. She is past president, Jabalpur Obstetrics and Gynecological Society. And she is the recipient of National Award for Pradhan Mantri Matri Surakshit Matrutva Abhiyan. We welcome both our chairpersons.
Thank you, madam. Our our next speaker is none other than Dr. Deepti Gupta. It is my pleasure to introduce young dynamic secretary of Ampogs, so all MP societies, and Dr. Deepti Gupta. She is member of MP SAR also, and she is the secretary Ampogs, MCM, MP SR, and MP SC EGOI. West Zone Coordinator, Foxy Quiz Committee, Nice and Peer Reviewer Jogi. She has won many awards. Foxy, Mr. N.A. Pandit, Mrs. Shelja Pandit Award 2024, Isar Dronachar Award 2023, CS Dawn Prize AICOG 2022.
Ma'am, can I start sharing?
Yes, yes, yes. And her topic is thromboprophylaxis in pregnancy. And I think we are going to enjoy her talk because she is a dynamic, wonderful, intelligent person. Welcome, Dr. Deepti Gupta.
Thank you so much, ma'am, for that kind and generous introduction. I know आप मुझसे actually बहुत प्यार करते हैं and your love and blessings are always with me. Is the screen visible?
Yes, it's visible.
Thank you so much, ma'am. And after that, Sumitra ma'am, indeed, it was one of the most clear, simple, no confusion talks that I have heard on hyperglycemia and pregnancy. Matlab, I hope some of our students were probably listening in and जो सुन रहे होंगे उनको मतलब ये होगा कि अब hyperglycemia की practice में I am sure कोई conflict confusion नहीं रहेगा. And after that phenomenal talk by Sumitra ma'am, who is such a senior teacher and seasoned speaker, I hope I can do some justice to this topic of thromboprophylaxis in pregnancy. So, yes, ma'am. Hopefully, I would like to share some practical insights, talk about updated guidelines, and finally end with actionable takeaways. This is the classic Virchow's triad of coagulation that we are all familiar with. We know that stasis, vessel wall injury, and hypercoagulability all contribute to formation of a thrombus. So various components of the hemostasis include coagulation factors, plasmatic proteins, the blood flow, vascular surfaces, and cellular elements. Now, why is it so tough in pregnancy? Because pregnancy may, on one hand, there is increase in coagulability. So pregnancy, we know, is a hypercoagulable state because of increase in coagulants. There is activation of clotting cascade. Of course, there is uteroplacental surface alteration as well, contributed by immunomodulatory effects. There is some amount of endothelial dysfunction and cytokine surge. Then there are hemodynamic changes. The plasma volume increases, there are changes in the blood pressure, and there is a definite venous stasis, which is worsened towards term. There is venous pooling, decreased return because of the growing gravid uterus. This is the coagulation cascade, which seems very confusing, but is very, very important for us to remember. And this chart, if you can appreciate, is just reminding us that, the activated partial thromboplastin time is going to cover these factors, 10, 9, 11, and 12. The prothrombin time is going to evaluate factor 7 and 10 mainly. And the thrombin time mainly covers fibrinogen, thrombin, and the fibrin action taking place. So now talking about thrombosis in obstetrics. Do we really know what is the prevalence of thrombosis in obstetrics? What are the various types of thrombosis or presentations which one can encounter? And the clinical relevance we are all very well versed with. The approximate prevalence reported in various papers is ranging from 0.5 to 2 per 1,000 pregnancies, with a very high case fatality rate. And thrombophilias are responsible for as many as more than 50% of the thrombotic events diagnosed during pregnancy and the postnatal period. About thrombophilias, we may encounter both hereditary and acquired ones, and the presentation varies from deep vein thrombosis to venous thromboembolic episode to pulmonary embolism. However, acquired, we know, more often presents with fetal or obstetric complications. Preeclampsia, recurrent miscarriages, fetal growth restriction, first trimester abortion, mid-trimester abortion, placental abruption, or intrauterine death are also various other clinical presentations of thromboembolic episodes in pregnancy. This is a very important chart taken from AREA's textbook, which talks about the various risk factors. Now, if we look at this table carefully, there are certain pre-existing risks, that is the acquired ones, which include non-obstetric causes like the a priori risk, so-called age more than 35, obesity, BMI of more than 30, parity more than 3, smoking or drug user, and pre-existing medical disorders like active SLE, diabetes mellitus, which ma'am just mentioned, especially if it is complicated with nephropathy, nephrotic syndrome, cardiac failure, sickle cell disease, a very common hemoglobinopathy in this belt that we are struggling with, paraplegia, varicose veins, etc., and history of previous venous thromboembolic episode. Then certain pre-existing risks, which are the obstetric group, that is pre-eclampsia and present pregnancy, multiple pregnancies, prolonged labor, postpartum hemorrhage, difficult operative vaginal birth, etc. Then thrombophilia related risks like inherited thrombophilia, which include AT3 deficiency, protein CS deficiency, and the acquired thrombophilia group. And then the new onset or transient risk factors, which include hyperemesis gravidarum, which is often ignored, dehydration, which could be a result of acute severe gastroenteritis, ovarian hyperstimulation syndrome with the increasing use of ART. This is another condition we need to watch out for, and any surgical procedure when performed in pregnancy. So a word about the classification of thrombophilias. As we can appreciate here, the hereditary group includes two main groups, the ones which cause decrease in inhibitors of coagulation. This group includes protein C deficiency, protein S deficiency, and antithrombin 3 deficiency. And the second is the elevation in coagulation factors, which will include activated protein C resistance, prothrombin gene mutation, factor V laden, and dysfibrinogenias. Interestingly, there is a risk-based classification as well. So the high-risk group includes antithrombin 3, protein C, protein S, and the acquired APS is actually a high-risk condition. The moderate risk includes activated C resistance, factor V laden, and prothrombin gene mutation. And hyperhomocystinemia is considered a low-risk condition. There is also some time and site predilection. Majority of the TVT present antenatally, and almost half of these can present before the 15 weeks of gestation. However, the major venous thromboembolic complications occur in puerperium, and a lot of them are seen on the left side. More than half of the DVT occur in the major lower limb vessels, iliofemoral veins, which have tendency to embolize and are often difficult to diagnose. So then what are the current recommendations for screening as per ACOG and American Society of Hematology? So if we look at the clinical scenario, if it is an unprovoked isolated venous thromboembolic episode or VTE provoked by surgery like cesarean or hysterectomy or unspecified VTE, then there is conditional evidence that says do not test. However, if there is a VTE provoked by pregnancy itself, provoked during a postpartum period, provoked with the use of combined oral contraceptive pills, or non-surgical transient risk factor, then the recommendation is to test for thrombophilias. And if there is associated history of individuals with family history of VTE, then we need to test for the specific thrombophilia known in the family. Now, moving on to the management strategies. This is a very, very tricky situation, walking a tightrope, where we have to balance the risk of anticoagulation against potential obstetric complications. There is a definite place of multidisciplinary team, and there are few common pitfalls with regard to testing, monitoring, the dosing, etc., which we make. So when we talk about thromboprophylaxis in pregnancy, it actually includes the non-medical measures and the medical measures. And the non-medical measures or the non-invasive measures, as we all practice in our day-to-day routine, is early mobilization, which can be a task to convince these women to move around, even sit up. Adequate hydration, again, is a huge task. Especially even in summer months, we see all our patients, मतलब वो कंबल ओढ़ के लेटी रहती हैं, and वो अजवाइन वाला unpalatable पानी उनके बाजू में रखा रहता है. Next important measure is calf exercises. Because of the muscular compression, the venous return is made better. And then, of course, we have the graduated pressure stockings, which can be considered in patients hospitalized, especially if LMWH therapy is contraindicated, or in post-cesarean women with high risk for VTE while they are still in hospital, and previous VTE which was managed on outpatient basis. So it was a very minor VTE, but इस बार चूंकि patient को risk है, तो she can be considered for the graduated pressure stocking option as well. A word about the unfractionated heparin. We must remember it is safe, no fetotoxicity, subcutaneous administration for prophylaxis. Standard dose of dalteparin is 5,000 units 12 hourly, and enoxaparin is 40 milligram to 60 milligram usually, depending on the body weight. In high-risk groups, therapeutic dose aims to maintain INR between 2 to 2.5. And in case of IV administration may be needed in an acute episode of DVT. The loading dose in case of when we are looking at managing acute episode of DVT, then the loading dose would be 80 units per kg bolus followed by 18 units per kg IV to achieve APTT of 1.5 to 2.5 of control. So this was about unfractionated heparin. Commonly, we use and are more comfortable with LMWH, which is again drug of choice for thromboprophylaxis. Baseline platelet count should be done, and after initiation, once after about a week, it can be done. In high-risk group, therapeutic dose should be 1 milliliters per kg twice daily. And for prophylaxis, it can be 40 milligram daily. Cost can be a limiting factor. However, the advantage is it has longer half-life. Another problem with this molecule is partial reversal with protamine sulfate. So if at all reversal is required, then we need to take into account when was the last dose of LMWH administered because of the half-life effect. So if the LMWH last dose was administered less than 8 hours back, then 1 milligram per kg protamine sulfate would be required for this patient. If it was more than 8 hours, then 0.5 milligram per milligram of enoxaparin or per 100 units of dalteparin would be required. But if the last dose was more than 12 to 24 hours, then because of the drug metabolism, reversal may not be needed here. A common concern with heparin therapy is heparin-induced thrombocytopenia, which is of two types, early onset or late onset. Early onset usually manifests in the first 48 hours. It is often self-limiting and it resolves in 5 days. It is the late onset which we need to be careful of. It is immune-mediated. The platelet count usually falls till about 50% of baseline, and it can cause bleeding or paradoxical thrombosis. And it often manifests after 5 to 14 days of therapy. However, platelets are not to be given. So other options which can be considered are heparinoids, direct thrombin inhibitors, and anti-10A inhibitors. There are certain contraindications to heparin therapy as well. Active ongoing antepartum or postpartum hemorrhage, history of stroke in the last 4 weeks, thrombocytopenia at the initiation of therapy less than 75,000 per ml, hemophilia, von Willebrand disease, etc., uncontrolled hypertension, and severe renal and hepatic disease. So these are again certain alternatives that can be considered. Now, coming to the VTE and DVT conditions. So this was the same table that we had covered, and why I have put it here once again is because it is going to guide the timing and the dose of thromboprophylaxis. So as per RCOG guidelines, the thromboprophylaxis is to be considered when there are 4 current risk factors. Then prophylactic LMWH is to be given from early pregnancy once the fetal cardiac activity has been confirmed, and it may need postpartum continuation after risk assessment. If there are more than 3 current risk factors, then prophylactic therapy will be initiated from 28 weeks. If there are more than 2 risk factors, then it can be considered only in the postpartum period for 10 days. If the patient is admitted in first trimester with hyperemesis or OHSs, that is any of the hormone-induced conditions predisposing to thrombosis, then patient should be offered LMWH unless there is a contraindication. In a woman with previous VTE, LMWH prophylaxis throughout pregnancy. Previous VTE associated with high risk thrombophilia, which we had discussed in the previous slide. Again, here there is a place of high dose of LMWH with postpartum prophylaxis for 6 weeks till oral anticoagulation can be initiated. Recurrent VTE on oral anticoagulant, again convert to heparin in early pregnancy. And asymptomatic thrombophilia, LMWH can be given throughout or from 28 weeks based on risk factors till 6 weeks postpartum. Similar comments have been given by ASH, that is American Society of Hematology. If venous thromboembolism is suspected in a patient, then we need to look at pain and swelling in the lower extremity, which are the two most common symptoms. Classic symptoms are, we know, acute onset chest pain, cough, and dyspnea. And clinical assessment by Well score is traditionally done. However, Well prediction rule, the utility in pregnancy is a little uncertain. But it says that we do the Wells prediction score. If there is low probability for DVT, then we do a D-dimer. If negative, then the likelihood of VTE is very low. And if the Wells prediction score is intermediate or high risk, then we need to do serial complex compression ultrasound to look for any developing thrombus. Treatment of acute VTE and superficial vein thrombosis. In a pregnant woman with acute venous thromboembolic episode, antithrombotic therapy is to be given with LMWH. With proven acute superficial vein thrombosis, again LMWH. There is no need for routine monitoring of anti-factor 10A level in these patients. In acute lower limb DVT, anticoagulation is preferred over catheter-directed thrombolysis in a pregnant patient. In acute pulmonary embolism and right ventricular dysfunction, anticoagulation alone. Systemic thrombolysis is to be done only if there is associated hemodynamic instability. Acquired antiphospholipid syndrome, we deal with quite often in our clinical practice. These patients we know often present with pregnancy losses, especially if there was a pregnancy loss after appearance of cardiac activity. We must always remember that 30% APS will have HTP, 30 to 60% will have preterm birth, at least a third will have fetal growth restriction, and 10 to 20% of women with RPL will be positive for antiphospholipid. And there is a clinical condition known as catastrophic APS as well. This is the famous Sapporo criteria, which we are all familiar with, which says one clinical criteria and one laboratory criteria must be present to form the diagnosis of antiphospholipid syndrome. The Sydney classification goes one step ahead and says that investigators are advised to classify APS patients into one of the following clinical categories, where we had only one lab criteria, 2A, only lab criteria present, 2B, lupus anticoagulant present alone, or anticardiolipin present alone, or anti-beta-2 present alone. Various proposed pathogenesis, abnormal placental function, narrowing of spiral arterioles, endothelial cell activation, and oxidant-mediated injury of vascular endothelium. Now here, again, the suggested subcutaneous heparin regimens are not the same. We have to remember that if the patient presented with only pre-embryonic or embryonic miscarriage, then the routine dose that we follow, that is unfractionated heparin 5,000 to 7,512 hourly, or if we are giving LMWH, then 40 milligrams or dalteparin 5,000 units once daily, or enoxaparin 30 milligram 12 hourly and dalteparin 5,012 hourly may be considered. However, if the patient had presented with fetal death after 10 weeks gestation or prior early delivery due to severe preeclampsia or placental insufficiency, then therapeutic doses, unfractionated heparin of 7,500 to 10,012 hourly in the first trimester, followed by 10,012 hourly in second or third trimesters. Similarly, LMWH, 30 milligram of enoxaparin 12 hourly or 5,000 units of dalteparin 12 hourly must be considered. So in APS in pregnancy, we know that we need to, on one hand, optimize perinatal outcomes and on the other hand, reduce the risk of thrombosis. Lupus anticoagulant negative pregnancy may be monitored with APTT, but here there is some place of anti-10A where LA positive pregnancy is to be monitored with anti-10A activity levels. And their antenatal visits also, along with ultrasound, would be more frequent compared to a normal pregnant patient. This is the Cochrane conclusion, which also states that in APS, heparin plus aspirin during the course of pregnancy may increase live birth rate. What about the labor or the postpartum management? Omit heparin on the day of onset of labor. In case of induction or planned cesarean section, heparin is to be omitted 24 hours prior for LMWH because of the longer duration of action and 12 hours for unfractionated heparin. If we are considering regional anesthesia, then last LMWH dose should be more than 12 hours or earlier. Resume anticoagulation as early as 6 hours after vaginal and 12 hours after cesarean birth in these patients. Dose should be adjusted to achieve INR of 2 to 3 in the postnatal period, and naturally estrogen contraceptive pills are going to be an absolute contraindication. Same ASH guideline states about anticoagulants at the time of delivery, that scheduled delivery with prior discontinuation of anticoagulant therapy should be considered, and pregnant women receiving only prophylactic dose can be allowed for spontaneous labor. This is conditional recommendation, and those who are on therapeutic dose, the best would be a scheduled delivery with a planned discontinuation of anticoagulant therapy. So in a nutshell, previous history with recurrent episode of VTE, heparin in the antenatal period, postnatal long-term anticoagulants may be needed. Previous history of single episode of VTE, prophylactic dose of LMWH is indicated. Asymptomatic thrombophilias, only vigilance may be enough in homozygous low risk and moderate risk conditions like prothrombin mutation and APLA seropositive only without any clinical criteria. And prophylactic LMWH is certainly indicated in 83 and homozygous factor 5 latent. APLA with history of obstetric complications again is a candidate for LMWH with aspirin. A word about the cardiac patients. If in first trimester, if on low dose warfarin, we can consider warfarin, but in a patient in other conditions, we consider replacement of warfarin by LMWH or unfractionated heparin because of the fetotoxic effects in first trimester. In second and third trimester, warfarin can be given and replaced by UFH close to term. After delivery, again resume anticoagulant 4 to 6 hours after delivery. Just a quick recap based on clinical situations. So this is the first case, 33 years old, gravida 3, para 1, abortion 1, live 1, normal BMI, no other comorbidity, previous LSCS, has come for booking visit. Would you offer antenatal thromboprophylaxis in this patient? The answer is no, because she has only one risk factor. The second clinical situation, she's 37-year-old. So one risk factor is here, age. Her BMI is 31. This is the second risk factor. She's gravida 3, para 1, abortion 1, live 1. And at present, she has twin pregnancy admitted at 10 weeks for hyperemesis. So this is the third risk factor. And the hyperemesis itself with multifetal gestation. So actually, these are two risk factors. So would you offer thromboprophylaxis in this patient? Certainly, yes. The third case, 30-year-old gravida 4, para 1, live 0 with 2 abortions, and previous 2 were missed abortions at around 3 months of gestation. Her third pregnancy was preeclampsia with abruptio placentae and IUD. On evaluating, she is also ACL positive. So thromboprophylaxis, definite yes, at higher doses as shown in the previous table. Definitely, as far as Indian subcontinent is concerned, we need more robust data to understand the prevalence and patterns of thrombotic episodes and thrombophilias in pregnancy. Specialist and resource management is especially very important, both in low resource and private sector, because in low resource setups, on one hand, we struggle with the availability of specialists and laboratory testing, and in the private sector, we struggle with the cost factor, because these are the cases who are going to require long-term and multidisciplinary care, probably with multiple or long-term admissions as well. So to conclude, pregnancy itself is a thrombogenic state worsened by multiple factors. Both hereditary and acquired thrombophilias can be encountered in obstetric practice. They can all often present with catastrophic presentations. High index of suspicion is very, very important. Multidisciplinary management for optimal outcomes. Resource management, as often they would need long-term hospitalization. And I think just like, as surgeons, we tend to fear the ureter a lot. Similarly, we tend to fear heparin therapy a lot. So I think it is high time that we need to start giving due consideration and importance to thromboprophylaxis in pregnancy. These were the references. And to conclude, such a mysterious business, motherhood, how brave a woman must be to embark on it. Thank you so much for patient listening.
Thank you, Dr. Deepti, for very lucid and informative and detailed, but easy to understand talk. And this is always so confusing when to start, when not to start. You have cleared it all our doubt, and I congratulate you on your wonderful talk. Thanks, Dr. Deepti.
Thank you, ma'am.
Thromboprophylaxis in pregnancy has always been an underrated and a vast topic, which we usually do not read on a day-to-day basis. Thank you, Deepti ma'am, for such a elaborate and making it interesting with all the case scenarios.
Thank you so much, ma'am. Ma'am, I can see one question in the Q&A box. Should I take that?
Yeah, please. In fact, I was about to talk to you. It was excellent, and I would say very practical, because it has to be. See, all of us are not students. All of us are practicing obstetrician, and the cases which you have to manage in day in and day out, those are the ones who actually you need to be individualized. So I would congratulate you for that. So Dr. Aarti Raghu, yes, she has. Yeah.
Yes, ma'am. So
Yeah,
Dr.
madam,
Aarti,
if
Dr.
there is just
Aarti has.
if
Yes,
there
ma'am.
is, if you can just spare 5 minutes, I would just want to share. It was an excellent deliberation, Deepti. Very, very, very well done. I just wanted to share. There was a patient who had 4 spontaneous. Around 13 to 14 weeks abortions. She was at Bangalore. She was put on thromboprophylaxis 2 times. Then when she came to Jabalpur, because घर वालों ने बोला कि advice rest वगैरह करेंगे, leave the job, and then she was at Jabalpur during the COVID time, and this time she did not want to take thromboprophylaxis. She was PIH also. I just put her on. I did IUI for her. Luckily, it came out to be twins. We just gave her Loprin and immune modulators. I put her on immunoglobulins every 3 weeks. So that took the pregnancy till 38 weeks. The day I told her section, ऐसा चला कि वो मुहूर्त इस टाइम पे है मैडम, कल करें परसों करें. And when she came, she landed in the hospital. We had already lost one of the baby. So out of the twins, the male baby we had lost. We immediately did a section for her. Everything went uneventful. मतलब Caesar सब ठीक हो गया. They were still very happy because they did not have even a single baby. तो उन्होंने बोला second तो हमें surplus मिल रहा था मैडम, एक तो हमारे पास हो गया. But 3 years later, and I gave her thromboprophylaxis for 5 days because she was very, very obese. 3 years later, I came to know that she was exercising in the gym and she had a clot in, she had a cerebral hemorrhage and a clot, and she was on ventilator for 8 days. और तब डॉक्टर्स ने बोला कि maybe the thromboprophylaxis should have continued for her. तो हमारी प्रेगनेंसी कंटिन्यू, मतलब we gave her the baby and that was the end of the story for us. But usually it is not so. You must follow these patients up, and she's okay. She's hale and hearty. She came out of the ventilator, but then because she's very, very close to me, I mean, I thought, why did I miss this? मतलब, so it was just an experience to share.
Definitely, and I think it is again an eye opener that we really need to keep this at the back of our minds and start looking for thrombophilias and triggers in such patients. So coming back to the question that Dr. Aarti has put, she has one patient with Sjogren syndrome, previous one IUFD at 30 weeks. So up to what gestational age should we give LMWH? I think it's clear, Dr. Aarti, she has to be given LMWH till 12 to 24 hours prior to the day you are planning delivery, which is sometime around 37, 38 weeks if her antenatal surveillance is absolutely fine. And God forbid, if she lands up in labor before that, then the heparin dose would be omitted the moment she lands into labor. And thank you so much once again, Sneha ma'am. Best wishes to you. Best wishes, Shweta di. And it was really a pleasure being here. Thank you so much, ma'am.
Thank you, dear. I was just wanted to project this slide that this
Yes,
is, I'm sure you have already covered, but these are the ones, the
yes.
risk factors which are pre-existing obstetric factors and the transient ones. So you have to score, give the scores. And according to this score, you have to see whether you need to start the low molecular weight heparin early during pregnancy at 28 weeks and whether it needs to be continued for 10 days postpartum or
Or
post-delivery
longer.
or 1.5 months or maybe even lifelong. That is
Yes.
what is the message I just wanted to give because this is what the algorithm says. Okay, so you have to
Yes.
start it I mean according to the risk and you have to continue postpartum according to the risk factors. So that is what actually I think we need to really learn this topic. People are very reluctant to have because this is part and parcel of our obstetric practice, may it be antenatal part or even the delivery and postpartum. So thank you
Absolutely.
so much
In
for.
fact, a lot of the patients, ma'am, in our medical colleges that we see and we label as complication of preeclampsia, sudden collapse, who knows, they could be presentations of various thrombophilias and thromboembolic events which are going unnoticed and not being picked up probably.
Yes, you're right. One more point here I want to just want to discuss with you, because X-ray has, APLA and hereditary thrombophilia. They, separate these two things. And
Absolutely.
they say that if even if you have RPL, but if she doesn't have APLA, then don't start with low molecular weight heparin unless it is in the context of venous thromboembolism. So, this is little tricky. So if you don't even follow the guidelines, so strictly or stringently, that is what I would say. Your experience you have to utilize here. So APLA with RPL 100%, yes, low molecular weight heparin. But the patients whom you find that there is a strong history or the risk factors are scoring more than 3, definitely you should start with the low molecular weight heparin. And that is all I think. Thank you so much, Dipti. So, Paulami, we can go ahead.
Yes, ma'am. So moving on to our next session, which is the last session of the evening and will be very interesting by our very own Dr. Sneha Bhoyer, ma'am. So there will be a panel discussion on near missed cases. So it will be a case-based discussion. So I would like to invite both the chairpersons, Dr. Anuradha Dang, ma'am. She is the director of Suvidha Hospital, Jabalpur. She has an accomplished career in high-risk obstetrics and oncology. She is the member of Foxy Gynec Oncology Committee. Our next chairperson is Dr. Kaveri Shaw, ma'am. She is the director of Vijaya Women's Clinic and Golden Women Care Hospital. She is the first robotic surgeon of Madhya Pradesh. She is the secretary, IMA Women's Doctors Wing, Jabalpur. We welcome you, ma'am. I would like our chairpersons to invite our panelists.
Good evening, everybody. At the outset, thanking Sneha Madam for giving us the opportunity. She's going to be, she's leading a panel on a very important day-to-day cases, which are a real nightmare for all the obstetricians, the near missed cases. And she has a beautiful panel, a very learned panel. Let me first invite Dr. Shazi Qureshi. She's the professor and unit head at SAIMS Indore. She has lots of publications and many awards to her name. Next, please. Our next panelist is Dr. Sapna Chaurasia. She's working as assistant professor at MGM Medical College, Indore, and she has a teaching experience of a very short time, but a lot of publications to her name. Next, please. Next, we have Dr. Mona Kothari. She has a vast experience of 20 years and managing high-risk pregnancies. Next. Next, from Jabalpur, we have Dr. Sneha, a very enthusiastic and a very upcoming gynecologist, and she is working very well in cancer, cervical cancer prevention, and she's doing very good work at Jabalpur. Next, please. Next, we have Dr. Priyanka Gaur, again a very active member of JOGS Executive Committee member. Next, please. And then we have Dr. Romana, very enthusiastic, very helping figure for JOGS, and Dr. Falak Raza, the most junior of all of the panelists. But then she's bubbling with knowledge, as we can see her most of the times on the stage. So with this, I hand over the mic to Dr. Sneha. Here are the master minds, and the panel is all yours, ma'am.
Thank you so much, Dr. Anuradha. In fact, thank you so much for accepting to be the expert for this panel. So without much ado, I would like to go ahead with the panel discussion. So friends, I welcome all of you, and just all of you think that she's just getting delivered vaginally, and all of you are eager to see that yes, that once she delivers, things are fine. But in no matter of time, you can find her in ICU. That is quite a common situation. So obstetrics is a bloody business, and unless everything has gone uneventfully, you cannot label that patient, having had a normal vaginal delivery as well. So it's not only the antenatal period, the intrapartum as well as postpartum period, everything is high risk, and that's the reason we are here. So maternal mortality rate. Today we are going to talk about near miss. That we have near miss is we have actually saved this patient, but has it not been the luck and the expert care on her side, we may have lost her. That is what is the ground reality. And we should discuss such cases to improve on our knowledge and practice, and also to analyze the causes of maternal mortality. So when we talk about maternal mortality rates and ratios, friends, these are not only numbers and figures. These are women. They have their faces, and we obstetricians have seen these faces in the phases of their distress, despair, and agony. And these keep on haunting our dreams. That is how it has been expressed by Muhammad Fathallah, the past FIGO president. And similarly, I'm sure we all feel so. Similarly, Ian Donald has also expressed it that looking back over the long clinical times, one tends to take it for granted the success, but it's the failure that stands out like a keloid. Reminding the person who has faced it, and of course a warning for others. So with this, we go ahead, because WHO says that near miss, or what it also labels as severe acute maternal morbidity, almost 8.23% of the maternal deaths in India are supposedly preventable. So that is why we have to come here together and analyze where we are going wrong. So friends, let us learn together. Never stop learning, because life never stops teaching you. So with this, I just present before you a very short warming up case. We have this second gravida, previous cesarean section. Last childbirth is only 1.5 years back, and she comes to you with UPT positive, 7 days overdue. She asks the doctor for medical abortion. The doctor prescribes the medical abortion pills, and she goes home. She on 6th day, suddenly at late night, she is brought to your hospital in a collapse state. And of course, when you examine, you find that her pulse rate is 132 BP, 70 pallor plus. And when you ask her, she just gives you history of, the relatives give you a history of only spotting and fainting attacks in between also. There's no history of external bleeding, excessive bleeding. So what is your diagnosis, Dr. Shaji? How would you like to investigate this patient and manage her?
Ma'am, since she is in her early pregnancy and was a case of previous cesarean scar, like previous LSCS,
Yes.
somebody who has such a fainting episode in early pregnancy after taking of MTP pills is very likely to be a ruptured ectopic pregnancy, which could be tubal, which could be scar ectopic.
Yes.
So these are my two differentials, which would be
Okay.
most likely.
Yes.
And I would investigate this patient immediately with a complete hemogram and an ultrasound to collaborate my diagnosis, clinical diagnosis.
Yeah.
Once I have the ultrasound documentation and the
I would
blood.
like to interrupt you here, Saji. You are perfect on your diagnosis. Yes, you have two differential diagnoses, which is going to be cleared on ultrasound. But your patient is collapsed. Blood pressure is only 70. So how
Yes.
would you manage this patient?
So initial resuscitation of the patient would be very important. We have to bring up the pulse, BP and everything in place. So the routine ABC management, that is airway, breathing and circulation, has to be maintained with two wide bore cannulas, rushing the crystalloids until the colloids and the bloods are available. And we'll arrange for the blood and blood products. And in case if the patient is in shock, you might require inotropic support for a time being.
Yeah.
And that is how we'll go about.
Her BP is only 17. She's got
So we will maintain the BP with crystalloids and then with colloids and until the blood and blood products are being arranged.
Yeah. Okay. So as long as you're, getting the blood and blood components, if you're getting the assurance that yes, you are getting it, you will not go for colloids. Okay. Go for crystalloids. Aggressive fluid resuscitation with crystalloids. Okay.
Yes.
The colloids have their own disadvantages. At this point, I will just say that yes, it is not a physiological solution. It can have anaphylactic reaction. It can worsen the situation. And definitely the coagulopathy also sometimes it can manifest with. So you're very, bang on the management. Yes, you have to resuscitate her. But meanwhile, simultaneously, you do investigation. By the time your lab report, takes time, maybe you go for bedside hemoglobin. You find that it is 7 gram%. And your ultrasound says, yes, there is definitely a adnexal mass and lots of free fluid in the peritoneal cavity. So you have a diagnosis as ruptured tubal ectopic pregnancy. Now, my simple question to you is whether you will go for laparotomy or laparoscopy and whether you will go for salpingectomy or conservative surgery.
Ma'am, see, it depends if you have facilities available and a trained, skilled anesthetist is available to take care of the blood pressure and the vitals. Laparoscopy is nowadays more better. But if you don't have the facilities available or you are not trained or you don't have a skilled anesthetist to take care of the patient in general anesthesia, you can even go for laparotomy.
Yeah, whether it is the anesthetist skill that decides or it is the laparoscopic surgeon skill that
it is both, ma'am.
Yes.
See, when the patient is vitally unstable, that GA will also create a lot of havoc. So we require both as a team, a skilled obstetrician, a good lab surgeon, as well as a good anesthetist to take care of the patient during anesthesia.
Right. So you have taken decision for laparoscopic, maybe you are a good laparoscopic surgeon. So now you tell me whether you go for salpingectomy or a conservative surgery for this case particular.
For this case, since it looks to be a ruptured ectopic pregnancy, so once the tube has already been ruptured, you don't need to save a bad tube. It is out of question then. So I would definitely go in for a salpingectomy because leaving such a bad tube will only invite future ectopics.
Yes.
So in that case, salpingectomy would be my go-to. Instead of a conservative surgery, this has to be only undertaken depending on the parity. If the patient has very bad obstetric history, her tubes are absolutely normal, and there is a well-recognized sac which is less than 4 centimeter or something. The tube hasn't ruptured. There's minimal blood loss. Patient can be convinced. Then you can go for a minimal conservative surgery.
Yeah, I would say, definitely in a very bad obstetric history, you may think of. Otherwise, when she has one living issue, basically she has landed up into ectopic pregnancy. That itself tells you that the tube is at fault, right? There is actually some fault in the tube, maybe just endosalpingeal lining, right? So it can invite ectopic pregnancy, as you rightly pointed. Now, what message you want to give? What is a learning lesson for this?
The most important lesson is that most of the times these pills are prescribed without, it's not mandatory to get an ultrasound done before prescribing a pill, but I would recommend with rising incidence of previous cesarean sections and increasing incidence of scar ectopic and PIDs and everything, there is very, very high probability of tubal ectopics and their subsequent ruptures on intake of malpracticed MTP kits. So this has to go down into our minds that without a baseline ultrasound of the patient for a intrauterine pregnancy, one should not prescribe MT pills, and especially to people who have previous cesarean scars.
Yeah, I would say even if it is not a previous cesarean scar,
Yes, even then
you have to make sure that the pregnancy is intrauterine, then only you should
then only
prescribe
give.
the
It is
medical
always
abortion
safer.
pills. And that to support, I would say, even if it is not mandatory by law, but it is recommended for the safety of the patient and safety of yourself.
Obstetrician. Yes, ma'am. Very true.
Thank you, Shaji. That is an excellent discussion. We go ahead with the second case now. Okay. So we have this 36-year-old lady, who conceived on IUI. Her husband works in Dubai and she stays in a village. So because it's a precious pregnancy, she comes to you for a regular ANC care. So, she asked you about this, how is the pregnancy? You say everything is perfect. She's lost to follow-up. Okay, at 34 weeks, suddenly she reports to a primary healthcare center, and then so with upper abdominal pain and pedalodema, when the medical officer examines. Sorry, the power failure, but I have joined from, So, I have changed the internet now, Wi-Fi. I have just joined back. Yeah.
Hello.
Can you see my screen?
Yes, ma'am.
Yeah. So, this lady now comes to the primary health center. The blood pressure is 176 by 116. Rest of the investigation, they could not be done naturally at PHC. Proteinuria and the hematocrit was normal. Her BP was measured at PHC. Naturally, it was very high. So the medical officer started her on tablet nifedipine retard. Okay, they just explained her that it's a severe hypertension. She needs to get admitted at the higher center. So this lady did not listen to them, and after 2 days, went to the higher center, where even on nifedipine retard, the BP was very high, 168 by 110. So they added tablet labetal, and of course started with Maxel so that she should not convulse. So they had a anesthetist also. They had a cesarean section facility. So went ahead with cesarean section. 1.8 kg live female baby was delivered, and the things were fine. Patient's blood pressure, irrespective of these two medications and magnesium sulfate, it was 140 to 180 systolic and 110 diastolic. Okay. So suddenly, 20 hours later, the patient started getting severe breathlessness, restlessness, and BP was 220 by 118. Pulse rate was very high, 115, and oxygen saturation dropping down to 70%. Her chest was full of wheeze, no clear breath sound. So, Dr. Sapna, what is your differential diagnosis here? How will you manage?
Good evening, ma'am. The first differential diagnosis in this case is it is the postpartum pulmonary edema, because she is the case of severe preeclampsia, and she is the history of the cesarean section, and also received the magnesium sulfate. And other differential diagnosis, as per me, is it may be the case of peripartum cardiomyopathy.
Perfect.
And maybe the pulmonary embolism or the medication
or adverse drug event because of anesthesia drug, or maybe the oxytocin, or maybe the magnesium sulfate.
Okay. So I would, the later two, I will not agree because it is after 30 hours of season, maybe 20 hours after season section. So oxytocin and this will not have its effect. Oxytocin has got a very short half-life of 5 minutes. Right? So, so other two are not there, but definitely, yeah, pulmonary edema, the catastrophic presentation of PPC, as you said, and pulmonary embolism. These are the three differential diagnosis. Perfect. So, how will you manage this patient?
We have to treat the underlying cause because there is the
No, she
high
has
BP.
presented to you as an emergency. So first you have to this emergency, right?
We have to shift the patient in the critical care unit, admitted in the critical care unit, and we have to give the antihypertensive drug and resuscitation, ABC, cardiac, respiratory, and circulation support. And we have to give the mechanical ventilation or respiratory support, and give the diuretics, loop diuretics to control the volume overload and oxygen supplementation.
Let me stop you, Sapna. She is already in the ward. So, you know, shifting this patient in ICU in such a bad condition will, you know, you may lose her in on the way. Yes, so you have to manage few things then and there only. So shout for help, get your anesthetist friend, get your physician or cardiologist friend, intensivist there and there only. And then you try to, you know, come her out of this situation first. So this patient was in propped up position, 100% oxygenation, Lasix 40 mg was given, IV labetalol was also given. Okay. So the anesthetist actually put the oxygen mask because her saturation was still there and she was still breathing. But after, you know, doing this, all this thing took at least 10 minutes. During that period, the oxygen saturation came down to 55%, even with 100% oxygenation. And the patient went into, you know, the patient, they tried to shift her to ICU, the patient went into cardiac arrest. Now, how will you manage cardiac arrest?
We have to give the cardiopulmonary resuscitation along with the mechanical ventilatory support.
How do you give CPR? How do you give CPR?
CPR,
yes.
Chest compression along with the AMBU, we have to give the 3:1. We have to give the CPR and oxygen supplementation.
How should you, where should you give compresses, chest compresses? How many chest compresses? This, like this.
3:1. Yes, ma'am.
The hand, you know, spread the hands like this and keep it on the lower end of the sternum, lower part of the sternum. And you have to actually, you know, lean on the patient and press it. And the press, how much you should press? The chest wall should be compressed by 5 centimeter at least. That hard you have to press it. Okay. And then at least 30 compresses and then 1 breath. 30 compresses and then 2 breaths. Okay. So that is how you have to go. If, you know, by the time, of course, you have to use the defibrillator if it is not responding to that. Okay. And then suppose now this patient, so if she is not breathing, you have to intubate and put her on mechanical ventilation, right? Okay. Yes. So your anesthetist friend and, you know, physician friends were there. They have, you know, managed this patient. They put her on mechanical ventilation. Within few minutes, she, you know, her blood pressure came down, came up to 88 millimeter of mercury. Oxygen saturation came to 90%. And within next 1 hour, she was on spontaneous respiration. Okay. So Dr. Mona, I would like to ask you for this case, whether this was preventable. You know, this was such a precious pregnancy. She was coming to the obstetrician. Whether we have missed something, could it have been preventable?
Yeah, good evening to all. That is like, it is very important for any pregnant female. There is ANC checkup is very, very important. From day one, when patient came to our clinic or to visit any gynecologist or obstetrician or anything, so day one is a very important to the day last. So ANC checkup is a very important whenever the patient first diagnosed as a blood pressure or hypertension, it is whether it is essential hypertension or a gestational, we should treat as early as possible to treat the patient or lowers the blood pressure in the normal limits. So when the patient came to ANC, this patient is a blood pressure is so much like we can say the it is a pre-eclampsia patient because the urine albumin and everything is positive. And see, you can see the
Okay.
Phase 3 now. So
Okay.
this we can by the good AC checkup we can prevent the or at least we can control the blood pressure of the patient.
Okay. I would like to ask all the panelists, Dr. Sapna, please put on your video.
Hello.
Yes.
Ma'am,
Yes.
nowadays preeclampsia is thoroughly a preventable condition.
Yes.
If
Yes.
you score the gestosis right in the beginning of the antenatal visits with the
Yeah.
high-risk parameters that you know of in the gestosis chart, like
Yeah. So
the
what
age,
are the parameters you would
the
like?
parameters are if the age is more than 35, if she
Yeah.
is primigravida itself is a very important risk factor. She is a ART conception with a high BMI, multifetal gestation, and
Yeah.
short
So
sperm
for
exposure.
this patient, age above 35 and of
Yes.
course fertility ART. Yes.
ART
So
प्रेगनेंसी थी, उसके बाद 35 इयर्स से ज्यादा की एज है, बीएमआई ज्यादा है, प्री प्रेगनेंसी पेशेंट का मीन आर्टीरियल प्रेशर मोर देन 95 मिलीमीटर्स ऑफ मर्करी रह रहा है, लो स्पर्म एक्सपोजर है, प्राइमी ग्रेविड, ऑल दीज विल यू नो. एंड इनफैक्ट आई वुड लाइक टू शेयर कि इन माय ओपीडी मुझे तो सबका जेस्टोसिस स्कोर 3 ही मिलता है.
Yeah. So
it becomes
why
so
is
much.
that? Why is that so?
Ma'am, because once I see primary, the score becomes 1. When you have a age, more of these females are mostly around 33, 35. And then you always get some kind of and they are very eager to get pregnant. So short sperm exposure and some degree of subclinical hypothyroidism is always present.
Yes,
So
that
when I
is what I
score,
wanted to know.
it is always 4. And
Yeah.
when it is 4, you have to mandatory start them on ecosprin.
How much?
150 milligram bedtime.
And so the message here is, my dear Mona, it's not only early detection. We go, we are, coming earlier. Screening, very important. You're very right on the management. We'll come to it, but screening, prediction first, and then prevention. So prediction is very important. The maternal characteristics, what you are talking about, what we now call it as HDP gestosis score, very, very important. You always triage your patient, and if you find the score more than 3, you start her on low dose aspirin, that is 150 milligram, and high dose calcium, that is 1.5 to 2 gram.
2 grams.
Please try to understand, this is 1.5 to 2 gram, not 400 milligram, 500 milligram. Okay, so that is one, that is prediction. Is it over prediction? No. Even at 11 to 13 weeks, when you do the NT scan,
mean arterial pressure.
One is mean arterial pressure.
Pape values.
Second is uterine artery pulsatility index. So two things, okay?
And the low Pape values.
Yes. So biophysical. So maternal characteristics, what we talk about HDP gestosis score. Then we have biophysical, that is the uterine artery pulsatility index. Then you have biochemical, that is PLGF and SFLT and the PAPE. Okay. So all this together, we have a very good predictive test available nowadays, and we have a very good preventive measure. So HDP gestosis is definitely preventable to some extent, but it is at least the complications can be prevented, and the morbidity and mortality associated can be prevented to a great extent.
In
right?
this, ma'am, it was a perfect case where not only the patient was mismanaged initially only, in fact, even in the post-delivery period, they had missed on Lasix, which is the cornerstone of management in the delivery patients of severe preeclampsia. It has to be given. It is very well written in areas that you have to start on 20 milligram of Lasix every day.
Dr. Shaji, I will take you little back. We have just finished screening. We have just finished prevention. Early detection. When, what I want to give to you, all of you, is that for any obstetrician, when you find such a high risk patient, you should never say that everything is normal. See, because the obstetrician said all the investigations are normal because she has not done it properly. Okay. So never say everything is normal. At this point of time, it is normal. But because you are a high risk patient, and otherwise also regular antenatal care is necessary, for a specialized care is necessary. Okay. That is what we have to stress. Secondly, when she was diagnosed as 176 by 116, was tablet nifedipine retired antihypertensive of choice?
No.
76.
Injectable labetalol.
One, but then she was at PHC. But what else can be given at PHC? Capsule nifedipine 10 milligram orally, right? IV labetalol and capsule nifedipine oral is equally effective. Let me tell you, over my 35 years of experience, I have used capsule nifedipine 10 milligram orally in and out. We may never, we may never land up into the situation where we have to use IV labetalol. Okay, so earlier and very appropriate use of capsule nifedipine is very, very important. So at PHC, they had given capsule nifedipine, and with that, if they had transferred her, things could have been better. Secondly, at sub-district hospital also, that with nifedipine retard, they are adding tablet labetalol. So here at least they should have given IV labetalol or maybe capsule nifedipine. That is how. And once the baby is out, no methergine, absolutely no methergine. And IV Lasix, as you said. Once the baby is out, you have to give IV Lasix because that will pull in all the blood into intravascular compartment. Loop diuretic has that role. So that was also missed. And when you have such a high risk patient, at least for 72 hours, this patient should have been in HDU or ICU or at least, very close monitoring. They shouldn't have kept the patient at sub-district hospital, right? So that is how it is. And then, of course, the rest of the things we have managed well. Okay.
And
so
I'm happy to share, madam.
I'm going to ask you.
The Pradesh,
Yes.
Even at PHC level, madam, they give Maxelf and shift the patient to us. So Maxelf is used even at the PHC level out here. So
it should be
so
given.
we are happy
You're right.
sharing.
You're right. At least the initial dose of magnesium sulfate should be given. You're right. In fact, I was about to ask you that anything else you want to comment on this. So that's a very good comment from you, Dr. Anuradha. I think we can go ahead, right? So we have this third case now. We have this 20-year-old young primary gravida, 9 months amenorrhea, and she's referred to you at around 11 o'clock at night. She was in labor at a nearby nursing home, small nursing home, right? So she was in labor for around 8 hours, and before that 3 to 4 hours at house at her own home. So almost 11 to 12 hours she was in labor, but she was getting strong contractions, but absolutely no progress. So they decided to take her for cesarean section. And when the sister catheterized her, there was no urine. So retrospectively, when they asked her, the patient and the staff and relatives, there was absolutely no urine over the last 10 to 12 hours. So they now got scared and shifted her to tertiary care center, where these people examined her. Otherwise, pulse rate was 110, BP was 110/70, uterine contractions were very strong, no relaxation in between, severe in intensity, and the fetal heart was going down to 100. She was only 3 centimeter dilated even with such strong contractions. Membranes were absent, station 0, and there was, brownish color, altered blood coming out. So what is your diagnosis, Dr. Roma, that I would ask you first, and then I would give you the investigations and everything else. Dr. Roma.
Thank you, ma'am.
Yes, hi.
Ma'am, she is the case of primary term with abruptio placenta with acute renal injury with fetal distress.
Yeah. And when we examined her, investigated her, hemoglobin was 8 gram% only, platelets 1 lakh. Her PT-INR was 2 and APTT was prolonged, right? So fibrinogen was low, 150 milligram%, and her FDP were present. So what is your diagnosis now after the investigations?
Ma'am, in abruptio placenta, disseminated intravascular coagulation is one of the complications.
Yes,
so patient may end up into DIC.
Yeah, she has already started, early DIC. So you're right, abruptio placentae with fetal distress, with query acute renal failure, we can say. And then, of course, she has got early DIC also. So how will you manage this patient? How will you manage this patient?
Ma'am, first we will take care of her.
So in other words, let me ask you, she's already having fetal distress. You want to take her up for cesarean section immediately or how?
Ma'am, I will go for cesarean section as it is not in active labor. Cervix is only
3 centimeter. Okay. Yeah. So whether you'd like to go immediately without arranging blood and blood components?
No,
Because
madam.
she's
First, I
already
will send her.
Mhm.
Again, I will send her investigation. We will arrange blood, PEG cell, and even blood product also FFP.
Yeah. Yeah, but everything has to be simultaneously. Everything has to be simultaneously, because you can't wait for things to get arranged, and then you have to activate all the protocols, and you have to get her into the OT also. Once they promise you that yes, we will give you some blood and blood components, you start operating, because at present one thing is she's got fetal distress, and once the placenta separates completely, you will have fetal death, right?
Yes.
That is one.
Yes.
Secondly, because the platelets are 1 lakh, so okay, she will not bleed that much. Definitely the FDP is higher, so by the time you will get the blood and blood components. Okay, so what you will start for her? What blood component?
Ma'am, we will arrange for PEGs, RBCs, and
okay. First
we
and
will
foremost,
correct the hypovolemia. Also, aggressive fluid therapy should be started, but we have to take care of fluid overload also.
okay.
We should.
Yes, Dr. Mona, you want to add something?
In approach this type of patient, we have to maintain the food very meticulously. So in that case, we have to avoid the FFP, cryoprecipitate, and PCV, everything we should be in hand, because it is mainly a pura coagulation abnormalities there. So to further look for the DIC, whether it will be converted into DIC or not, so we have to be in hand, or have to at least call all this company.
Yes, because she's already in early DIC. We're talking about that. So what I would like to draw your attention, my girls, see, her blood pressure is 110/70, but her pulse rate is going higher and higher. Okay. So, and her urine output is 0. That itself tells you that she's into anuria, and that has happened because of hypovolemia. So even though you feel that the blood pressure is normal here, it may have been very high, because of which she has landed up into aberration, right? So aggressive fluid resuscitation once again, to bring back the normal circulation and GFR, and of course the urine output. That is one. And then you arrange for the blood and blood components and take her for cesarean section immediately. Of course, what precautions you want to take during this cesarean section? Yes.
Hello.
Yes, go ahead. Please go ahead.
During this cesarean section, the most important thing is there should be a very trained, expertised obstetrician who can deal with coagulopathy, because there might be intraoperative blood loss, excessive blood loss, and a trained anesthetist as well. We might require an intensivist in the post-op period also, and a neonatologist. So there should be a complete thorough team of 4 people.
Yes.
One very important thing is, then blood and blood products will be very important.
Yeah, we'll come to it that. But then the point you have taken, raised, that is very important, that this APH may continue as PPH for 2 reasons. Because she's got abruptio, so the cuvellar uterus, it is difficult to contract. So you have to give carbetocin for such patients. Prophylactically, you use prophylactic management for PPH. Right.
So before starting the section, I might insert pervaginal misoprostol tablet, arrange for carbetocin, and you might require sometimes for atonicity surgical suture also, like B-Lynch or something. And then during intra-op period also, I would like to put a drain also, ma'am. In such cases where there is coagulopathy, I prefer to put an intra-abdominal drain, so as to see the post-operative blood loss which might happen because of the continuation of the DIC in the post-operative period. So that is one important thing. And then going for quick cesarean section.
Yeah. I think the once you have all the arrangement done, quick cesarean section is very important. For 1 lakh platelet count, I think if at all you find that there is not much of oozing, Dr. Shaji, we would not go ahead with any drain, maybe. Okay.
Ma'am, she has an INR of 2.
Yeah. But INR of 2 is not, it doesn't lead to bleeding tendency. If I tell you, people who have got history of coagulopathy or hemophilia, some sort of hemophilia, when they are on some anticoagulant, no, maybe warfarin or even other anticoagulant, they are advised to keep their PT-INR in between 1.5 to 2, I mean, more than 2. 2 to 2.5.
But ma'am, this patient is normal. Like she must have been pre-eclampsia or something. So
Yeah.
INR of 2 is dicey. INR of 2 can be a bleeding tendency.
Yeah.
Because
So
the
that
cutoff
is
is
what you have to
1.5.
take. Yeah, that is why you have to take a decision intraoperatively. If you find that she's oozing, keep a drain. If you find that everything is clean cut, absolutely no problem, you are happy, because by the time you are infusing lots of blood and blood component, right? And of course, you are monitoring the bleeding and clotting time and the repeat PT-INR post-operatively, right? So good that you raised that point. It's a very valid point for all of us. Okay, so you have gone ahead with the management, and definitely for now for fibrinogen 150 milligram percent, do you want to make any comment? Fibrinogen?
Yes, we can have cryos transfusions for this low fibrinogen levels, and that will be according to the fibrinogen levels. We can arrange for 4 to 6 precipitates and transfuse the same.
Yes. So I have that chart. I think maybe for the next case we will go for it. So fibrinogen concentrate of cryoprecipitate FFP if available, because FFP is the one which you get readily. So FFP also can be transfused fast, right? So we have already talked about this, that it's not only giving blood and restoring volume, but also restoring the coagulation factors, restoring the hematocrit, and also the electrolytes as well. Okay, so that is how you have to monitor this patient. So we come to Dr. Falak now. Dr. Falak, yes. Yeah, hi. So we have this 32-year-old para 1 previous cesarean section patient. She has got one male child, only 1 year old, and she has now come to you as, this is her first antenatal visit to you during 6 months, because she just recently transferred from some other city to your city. She comes to you with history of bleeding PV and at home. So once she reaches the hospital, the bleeding is stopped. But when you ask her in details, then she tells you that yes, there was a history of little spotting during early pregnancy. When you see the ultrasound report, yes, the placenta is low lying. And when you do her ultrasound, you find that yes, the placenta is low lying anterior, and there is absent retroplacental lake, and there is lots of vascularity in the lower uterine segment. So this patient you have already diagnosed, and you sent her home. At 30 weeks, she comes to you with bleeding at home significantly. When she reaches your hospital, she's collapsed. Now, how will you manage this patient? What is your diagnosis basically, Dr. Falak?
The diagnosis is placenta previa with acrita.
Right.
Because since they're the absent RP lake, so it is acrita.
Yes.
And ma'am, when the patient is presenting to me as she's in collapse state, the first I will resuscitate her.
Right.
Immediately I'll call for help and arrange for resuscitation, airway, breathing and circulation. I will first aim in that. Then arrange for blood. When she settles down, I will, since I know that she's already having placenta previa, so I have to take her up for emergency cesarean section then.
Okay.
And meanwhile, since she is 30 weeks, so if there's time, then we can give for the baby, we can give her steroid. And meanwhile,
she's collapsed, my dear. How
the patient is collapsed. First, I will resuscitate her, ma'am.
That
First,
is okay.
I will resuscitate her, stabilize her, arrange for blood transfusion.
That is okay. But then for the baby, you want to wait, or you want to take her?
No, I don't want to wait. I will immediately. I will take her.
Steroids will not work. Steroids will not work. They take 40 to 72 hours,
No,
and we are not.
Okay, ma'am. I will take her up for emergency cesarean section at that time.
Okay, so Palak, just wait. Give me a moment. This patient has come to you at 6 months, and now she's collapsed. Okay. Suddenly the relatives, you are telling them that we are not sure what is going to happen. She's bleeding a lot. We need maybe 4, 6 blood, and we have to take her for cesarean section. She's just 30 weeks. You need to counsel them regarding the baby. So Yeah.
Yes, ma'am. I will counsel her on the first visit itself. When she comes to me for the first
That we come to, you know, whether it was retrospection will go. But this patient, when you are managing as an emergency, okay, you have resuscitated her, but you are talking to the relatives. So what will you talk about the patient's condition as a mother and the baby? You tell me.
Ma'am, I will counsel
The
the
private
patient.
hospital, yes.
Yes, ma'am. Ma'am, I will counsel the patient's relative regarding the patient's condition that she is in high risk case, ma'am. Definitely, I will tell her that I will not tell her about that she is in, so that the attenders don't panic. I will just counsel them accordingly and tell her that the need of hysterectomy may be required because it's a placenta accreta and patient has collapsed because of this only and she started bleeding. So I have to do an emergency C-section to save the mother. And meanwhile,
whether it is C-section or whether it is planned obstetric hysterectomy.
Ma'am, it is in this case, it is a planned.
Because
But this is now patient is collapsed. This is an emergency condition, ma'am. In emergency condition, I will take her up and I will counsel the attenders that I have to go for a hysterectomy because otherwise patient will be in very great difficulty. I have to counsel her for hysterectomy, ma'am, beforehand only.
So, you know, for collapse patient, you have no choice for conservative surgery.
Yes,
okay?
yes,
That
yes.
has to be very, very clear. And
Yes,
you have
ma'am.
to tell them that this cesarean section we are doing or obstetric hysterectomy we have to go. This is for the patient's interest. It's the interest of the maternal life. Okay.
Yes,
You
ma'am.
don't say that they will become panic, so I will not tell them.
No, ma'am.
You have to tell them.
I have to balance out and tell them. Ma'am, yesterday only I had operated one case. Luckily, she was a case of placenta previa with there was loss of RP leg, but ma'am, we were able to save the uterus. So I had counseled them for hysterectomy, taken the consent beforehand only, but luckily we were able to save the uterus.
Yes. So
She was a case of
you promise less and deliver more. Okay,
Yes,
that's okay. You take consent for hysterectomy, and then if you succeed, maybe save the uterus. That is different. But you take a consent. Otherwise, you know what the relatives will feel that you have taken her inside and you have done some blunder, and because
that is why you are landing up into their hysterectomy. Yes, ma'am. Absolutely.
Okay, so one thing is informed written consent for obstetric hysterectomy.
Yes,
what about the baby? They will say you are doing Caesar, then why the baby will not survive? You have to explain them.
Yes, ma'am. We have to explain it to them that we are not we can't take the guarantee of the baby because it's a premature. It is very premature.
Try our best.
We are trying our best. We'll arrange for a pediatrician immediately.
Neonatologist.
Neonatologist immediately and
Okay.
shift the baby immediately to the NICU care.
Right. Okay, so the relatives, because now it's a panic situation, the relative says, the doctor, do whatever you save our, save our lady. Then you have taken her for now operative procedure. So whom all you want in your team? Who all?
Ma'am, we have to include in our team, ma'am, we have to arrange for a very good anesthetist. And ma'am, we have to arrange all the accessories for ma'am, we need blood also during the surgery because it's...
No, I'm asking you your team. And all in your team, whom all
we need an expert surgeon, ma'am, since we have senior gynecologist, expert anesthetist, neonatologist, and surgeon also, ma'am.
Yes.
In our team.
Whether you want surgeon or given a choice, whether you want neurosurgeon or suppose you have, surgeon, which one you will prefer?
Neurosurgeon.
Neurosurgeon, because it will strengthen the ureters. And anybody else you want? Suppose you have every facility, it's a multidisciplinary center. Anything else? Interventional radiology.
Intervention is, yes,
okay. So in addition to blood bank, definitely. Okay. Yes, okay. So you have all your team ready. The interventional radiologist has already, done UA, uterine artery embolization for you pre-operatively. Okay. And now when you open your, now you tell me, how will you take the incision?
Hello.
How will you take the incision? The abdominal incision, the uterine incision?
Ma'am, abdominal incision, Phenencian incision, I will take per abdomen, or vertical incision also I can take, ma'am. But
I will differ on this.
Palak, wait. Why I'm asking you this question? because all of you are taking financial incision, right? So for this case, why I want to ask you?
It has to be a vertical incision. Because we will definitely, it's a no touch technique. You don't have to touch the placenta accreta. Matlab, you don't have to enter into that zone. So it has to be a vertical midline incision. Go by an abdominal vertical midline incision. Open the uterus by a vertical incision without touching the placenta. And then with
No,
placenta.
but then whether you take a vertical incision or a transverse incision, what difference it makes?
Ma'am, it'll be a vertical incision on the abdomen. Deliver the uterus. Do either a transfundal or a vertical incision without touching the placenta, which is already adherent. And then with placenta in situ, proceed with a hysterectomy.
Okay, okay. But then people are okay with liberal transverse incision also. Yeah, people
That
are
is what
okay
I'm
with
saying.
liberal. So, I mean, okay, no problem. You can go ahead. But then definitely, as you said, we all of us agree to it, preferably a vertical incision. Okay?
Preferably
Because
a vertical.
you want this, liberal incision. You don't want the uterus to be manipulated. That's yeah. And one more reason is maybe you have to go for the internal iliac ligation in addition to obstetric hysterectomy, and that is why you don't want to waste your time stretching, pulling, retracting, and that is why you want a liberal incision. Now you tell me, who was talking? Falak, we continue with you. We have entered the abdomen. Now, which incision on the uterus?
Ma'am, a vertical incision?
Where?
Ma'am, fundus. Near the fundus.
Okay, so vertical incision on the upper segment. Perfect. But if you see that, the whole of the upper segment also is very vascular, then maybe you have to go for transfundal.
Transfundal.
Yeah, just take a transverse incision at the fundus, remove the baby, deliver the baby. Don't touch the placenta. Okay. So then what you do?
Ma'am, immediately when take out the baby and transfer it to the neonatologist, and then we don't have to touch the
placenta. You don't bother about
the baby. We
Let
have
other people,
we have to we don't have to touch the placenta. Then go ahead with, we have arranged for the hysterectomy clamps and all. Go ahead with the hysterectomy part, ma'am. We don't have to waste the time in between. Because there will be a much blood loss and all. So we have to go ahead with hysterectomy.
Yeah. So what about these cut edges? You will apply multiple green armitage forceps.
Yes, ma'am. For the open wound is there on the uterus, we have to apply instruments so that there is bleeding, green armitage forceps, so that there is a reduction in blood loss. And then go ahead with hysterectomy, ma'am.
Okay. Then you go ahead with hysterectomy in what way? How do you do the hysterectomy? And there's a special technique for this. I mean, don't slowly clamp, cut, ligate, transfix, nothing. Just clamp and cut, clamp and cut. Go ahead and you remove that. Whether it is atonic PPH or whether it is placenta accreta, don't wait for the bleeding. You remove the uterus first and then you secure your pedicles, right?
Yes, ma'am.
Yeah. Suppose now you initially you just thought it is adherent placenta and it is there in the lower uterine segment, maybe just accreta or increta. But when you open the abdomen, you find that there is absolutely large vessels running across the lower uterine segment and the bladder. Now, how do you go ahead with this? You are not able to separate the bladder.
I mean, such cases it is ideal to post such cases as an elective procedure with a
yes, but if our patient has collapsed, no, we have no option, right?
Ma'am, then a urologist will take over from there. It might require a partial cystectomy or a bladder repair. And
bladder repair
if we get a ureteric cannulation done, DJ stenting prior to opening up
that
such
is what
patients.
I'm saying, that the urosurgeon or the radiologist will do a stenting for you. You will do a uterine artery embolization. So aram se you can do the procedure. No hurry. Now you have to separate the bladder from the lower uterine segment. You have the catheter already in place.
But right now?
Yeah. Yes. Sometimes it may happen that, from the myometrium, you may have to actually cut the bladder, maybe separately. Either it gets traumatized, maybe sometimes, you have to actually intentionally
separate the bladder.
and then you do the repair. That is very easy, right? So that is how it is, but you don't leave any placental tissue inside. That is what is the intention, right? So now you tell me, what is the post-operative management for this patient? Any specific, suppose you find that, suppose this patient, now this patient was not that silent patient. She was bleeding profusely and she was collapsed, right? So naturally, even when you are removing the baby before incising, also she is bleeding a lot. So your aim is to remove the uterus first and then you manage everything. Suppose you find that it is percreta and she's, oozing, bleeding from everywhere, then what will you do? In that situation, there is a place for internal iliac ligation also, right? Because in spite of all this, if the stump keeps on bleeding, if the pedicles keep on oozing, then of course you have to go for internal iliac ligation. But suppose this patient was collapsed, as you said. Suppose now we would go retrospectively. What has gone wrong for this patient? For the obstetrician.
First,
yeah, tell me.
Ma'am, we have to counsel them beforehand only. These episodes of bleeding can happen her at any time during the pregnancy. And this may lead to this condition earlier. We have to explain it to the relatives pre-annually, so that she, first of all.
But wait, she has come to you during 6 months. She was diagnosed with you. So she should have been hospitalized at that
time.
And then, yes.
And then counseling should have been done beforehand only, that this may, anytime she can land up into emergency C-section with cesarean.
What precautions?
Avoid lifting heavy weights, ma'am, and avoid.
Could we come to Dr. Sneha? Do we have Dr. Sneha on board?
Yes, ma'am. Yes, ma'am. I'm audible, ma'am?
Yes. Welcome, Dr. Sneha. So, this patient, you have heard all the discussion. Could it have been prevented? Do you want to see, she was diagnosed in 6 months, or maybe little earlier she would have been diagnosed actually. Would you like
exactly, ma'am.
Yeah, would you like to, would you have preferred to give cerclage for this patient or any tocolysis for this patient?
Madam, I don't feel that tocolysis or cerclage will work. Instead, if she would have done target scan at earlier 18 to 20 weeks, we could have come to know the location of placenta and retroplacental space also. And the TVS could have been done for the better confirmation of placenta previa. And cervical length measurement is also an important predictor, which gives a indication for which gives the prediction for the preterm labor of the patient.
Right. So
that was missed, and when she came at 6 months, so she should
just
have
one message from this slide that what you said is yes, I will not go for it. Absolutely fine. The message here is that absolutely no question of giving cervical cerclage for this patient, because there is absolutely no indication. It's not a short cervix. In fact, sometimes you may just prick the placenta because it is low lying. Okay, so absolutely no for cervical cerclage.
Do harm rather than giving her benefits.
Yes. And tocolysis, because she doesn't have uterine contractions or pain. So there is no question of tocolysis. That is one. Secondly, long-term tocolysis is absolutely contraindicated. Nowadays, we don't give long-term tocolysis, right? Tocolysis is only short period, 2 to 3 days, till the time the steroids act. Okay, so long-term tocolysis, no. Now we come to what could have been done, as you said rightly. Yes, go ahead, please.
Target scan could have been done, and we could have locate the placenta early, and we could have diagnosed placenta previa early. And if we diagnose placenta
also, you said,
short cervix also we could have diagnosed, and we could have tell the patient
once
if it is
diagnosed, what will you do? That you tell me.
Yes, ma'am. Once we diagnose, we should consult the patient that it is a placenta previa. That means placenta is implanting on the lower uterine segment. So you should be very cautious. There should be no intercourse. You should not lift heavy weights. You should not travel. You should not strain. And if any time you feel like there is a bleeding or there's a spotting, you should immediately report to the doctor. And you can have a personal or emergency number of the doctor or hospital, so that you can inform and immediately you can come and get yourself admitted and treated for the placenta previa, so that we can.
I would say prophylactically you hospitalize this patient, because it's a very high risk woman. And secondly, you tell me that whether you would like to keep her in your small nursing home, or you would advise her to get admitted in the tertiary care center.
But I would
Thank
like to tell her to admit in the tertiary care center because there we have the facilities for intensivist, anesthetist,
Everything. Right.
surgeon, also everything. Yeah, and if anytime we need blood transfusions, and we could have a multi-specialty team over there, so that I will advise them to get admitted in the multi-specialty or like a tertiary care center rather than in the small
Right.
hospital.
And what was the mistake done by this obstetrician when she came to her at 6 months when she was bleeding, when she was diagnosed? She should have,
And she was not advised for admission. That was the,
to
I
the
think,
tertiary care center, to the tertiary care.
yeah, that was a
you. Go to
mistake.
the heart center.
So, Dr. Priyanka, do we have Dr. Priyanka?
Yes, ma'am. Yes, ma'am.
Yeah.
I'm here.
Yes. Hi, Priyanka. Where are
Hello,
you?
ma'am. I'm
Yeah.
here only, ma'am.
I'm not able to see you. Yeah, let me just, yeah. Okay. So, Dr. Priyanka, what are the special precautions? I have already we have already talked about the abdominal incision and the uterine incision, and you should just deliver the baby, don't touch the placenta. I would just ask you one question, whether see, suppose, can we leave this placenta in situ and close the uterus? What
Madam,
is your view? Yes.
specifically regarding this patient is already collapsed. So she must be bleeding heavily from the placental side. So
Right.
placenta could not be left in this particular case. But if
Right.
the placenta is not bleeding in any other condition, then we can leave the placenta completely in utero.
Okay. But then
Ma'am,
what is
I would disagree on this actually.
Yeah, that is what I'm
In
saying.
the
One
current
sec, Haji, one sec. We would like to have other panelists' opinion also. What is the role of leaving behind? I mean, is there any place for leaving behind the placenta in situ? Whether you want to give her methotrexate? What is your view, Dr. Sapna, Dr. Mona?
No role of
Then
methotrexate.
last word by expert. Yes, Sapna.
No role of my
Ma'am,
methotrexate.
the patient is hemodynamically unstable, so there is no role of leaving behind
There's no question of hemodynamic. I'm asking you very clearly. Even if the patient is stable, whether you would like to leave this placenta in situ, yes or no, and whether you would like to give methotrexate, because this is
Ma'am,
very
there is no role of methotrexate.
no role
Yes.
of
Ma'am, there is
no
no
role
role
of
of
leaving.
methotrexate in this case.
Yes. So yes, Dr. Anuradha.
Palak.
Yes.
Yes, madam. Even I agree. There is no role of methotrexate for such a big chunk of placenta. A small piece or something, maybe it will work, sometimes, but otherwise, no role for leaving the placenta in situ.
Yeah. So now, Shaji, you want to comment? Yeah.
Ma'am, now it has been proven, I mean, except for a few cases on record, it has been seen that the amount and significant damage that happens with leaving such placenta in situ, the kind of sepsis, secondary hemorrhage, and DIC with which the patient lands is far, far bad as compared to operating in the first go. So it is better to, it's a life-saving condition. And we must always think in the primary interest of the mother rather than being more conservative. So, because anytime if this placenta, see, eventually what methotrexate will do, it will shear off the placenta, and we know that placenta is located in the lower segment, which is poor retractile property. So eventually it will bleed, and the patient will land in secondary hemorrhage. Now, opening the patient all the way second time is no good option.
Yes. So let me share with you first the experience and then the evidence. Okay. So way back 35 years ago, when we were the PG students, we have had such experiences, and that time we, even after maybe vaginal delivery or maybe even cesarean section, that time we have had conservative approach, because there was no other way, and that time we did not think of hysterectomy. So methotrexate was given. Okay, I'm sharing the experience. Then we go to the evidence. So some of the cases we were fortunate that slowly, the placenta was necrosed and shed off and thrown out, expelled on its own. So we were lucky enough. But few occasions the patient went into septicemia. She landed up into secondary hemorrhage, DIC, and even after doing hysterectomy in those patients, we could not survive them. Okay, we could not save them. So that bad is leaving behind the placenta. One. Secondly, methotrexate does more harm than the benefits in this condition. The scientific evidence says that Methotrexate acts only on rapidly growing cells or rapidly dividing cells and not on this necrose tissue. Okay, very clear. So absolutely no benefit. In fact, lots of harm. So the evidence says nowadays all our parent body, including FIGO, says there is absolutely no role of keeping behind the uterus with the placenta in situ. It's like a hanging sword. You know, anytime the patient can go into secondary PPH at maybe 1 a.m., 2 a.m., and you have nobody to help. Okay, so best way is all or none. Either you tell them that maybe we have to go for conservative uterine surgery if at all possible. That will be at this point of time. Dr. Priyanka, you want to say something? Yes.
Ma'am, I wanted to ask you, not leaving the placenta behind is indicated only for low-lying placenta or in all cases of placenta? Because
All
sometimes
cases of placenta, all cases of placenta. Because see, anything which our evidence doesn't allow, I don't think we should dare to go ahead. Okay. So because whatever you are doing, and if at all you land up into complications, if the evidence doesn't support, that goes against you. Okay. So best thing is to go ahead with either obstetric hysterectomy, well and good if the relatives agree to it and things are fine. If at all they want to go for conservative uterine surgery, not for this patient, as you all know, if a patient is hemodynamically stable, she is not bleeding, and then you try to go for the obstetric, uterine conservative surgery. Yes, there are different methods. Triple P procedure where you have 3 Ps. One is placental mapping, that you do MRI, map the placenta exact, depth of invasion and even the level where up to where it is. So you are not touching the placenta. Once you remove the baby, deliver the baby, you go for what is called a second P, that is pelvic devascularization. So you go for bilateral internal, you go for internal iliac, you go for bilateral uterine artery ligation, so that you make the uterus absolutely avascular. Okay, and then you now go for what is called as the high up anterior uterine artery ligation. At both the ends of this cesarean section, you go high up and occlude both the uterine arteries with the deep through and through stitches on both sides. And now you scrape out the placenta when everything is avascular. Okay. And then maybe if it is not coming, that is what is called as patchy myometrial resection. So in that also, even if you have to cut the myometrium little bit, that is okay, how you incise for the seizure. And then you close it approximately properly. So that is what is, you have either triple P procedure, or you have what I have just described is called as Comog MG stitch, that high up anterior division of internal iliac or the uterine artery ligation. That is the second uterine conservative surgery. Okay. So I think that should be all for this case. If at all you get this kind of cases, definitely I would say that, all of you have to be ready. Now coming to this coagulopathy, I had some information just to say that, points to remember that packed cell volume, PCV gives you 250 ml of volume only. Fresh frozen plasma gives fibrinogen as well as all clotting factor, and that is 240 ml. Okay, so when you have fibrinogen less, then that case you have to use FFP. And how much FFP that you need to calculate, that I will be telling you. Platelets, if it is 1 lakh, well and good, you don't have to give it. Cryoprecipitated, 5 to 20 ml the volume is, but it has all the factor 7C, von Willebrands and fibrinogen. So all these clotting factors here. Here I was talking about FFP. So for an average 60 kg woman, if you have that, how almost it is hardly 240 ml. So you need 5 packs of FFP at least to get 1200. Okay, so that is how is the, so rest I think I have 2-3 more cases. Should we discuss or should we stop? It's already 8:30. Should we stop?
Yes, ma'am.
Yeah, I will just go to the last case and ask Dr. Priyanka. Yeah, and one more panelist, I think, Dr. Sneha. We would like to listen to you. We have this, this is a short case now. I'll just go ahead with grand multipara. She had one vaginal delivery, not one vaginal. She has had 4 vaginal deliveries Now this is the fifth one, and she comes to you with obstructed labor, tachycardia, etc., fetal thick meconium state like. So you take her up for cesarean section. 4 kg distressed baby is delivered, that is resuscitated and shifted to NICU. So there was only little extension of the incision that was also repaired well. There was absolutely no significant blood loss during the procedure, that is intra-op, and even post-op there was no bleeding. Then maybe around an hour after the shifting her to the ward, the patient, suddenly had very excessive sweating, thready pulse, and disturbed respiration, confused look, and vomiting tendency. So when you examine, there was no pallor. There was no signs of internal bleeding or external bleeding, and uterus was also well contracted. So what is your diagnosis, Dr. Sneha?
Since the BP has fallen suddenly, so immediately we will have to manage the patient first.
What is your
And since
diagnosis?
the
What is the diagnosis, I'm saying?
ma'am, since the patient was unbooked, there are no investigations were available. So we will do some immediate investigations like CBC and blood sugars.
Okay,
And
but then from the history, the
maternal
diagnosis is,
collapse.
yeah,
Yeah,
it is
diagnosis is
maternal
not
collapse.
it's a maternal collapse only, and
I
we
would
don't know
say,
what is the reason.
yeah, but then she has no signs of internal or external bleeding. So it is a non-hemorrhagic shock. Okay, that much we are sure. And then, of course, you are managing this patient, aggressive fluid resuscitation, etc. You are giving vasopressors to the, her BP should come up. By the time you are doing her bedside investigations, trying to get her health, so hemoglobin bedside is 10.8 gram%. Sugar is very high, around 550 plus. Urine sugar is 3 plus, ketones are 2 plus. Now tell me, what is your diagnosis?
Diabetic coma.
Diabetic
Ketoacidosis, not coma, ketoacidosis. Okay, so Dr. Priyanka, this is the only question for you. Whether we could have prevented this situation, this catastrophe?
The precipitating factor for diabetic ketoacidosis is, ma'am, dehydration, sepsis, use of corticosteroids, and in this case, it is mostly dehydration and maybe sepsis also.
Yes,
So,
my dear, but then she was not diagnosed as
She
diabetic.
was not diagnosed. Yeah, previously the
she was
blood
not diagnosed
investigations were
also.
not done.
That is
Yeah.
why we planned for the talk, tackling hyperglycemia. Okay, so she was not diagnosed. You're right that, once you know that, you will take all the precautions. But she was not diagnosed. She came to you as
Patient came in emergency, yeah, and she was an unbooked case, and the no blood investigations were available. So at least if we would have the blood investigations available, like sugars are higher, hemoglobin is on lower side, so we could have diagnosed it early.
Yeah. So the only message from this case I want to see, you will get your physician friends help, you will get anesthetist, you will manage intensivist, you can, manage later on. But why she landed up into this condition? Because she was never screened for that. Okay, so this is the simple message that every woman during every pregnancy should be screened. And then, of course, comes as, this diabetic ketoacidosis, the fluid therapy, etc., insulin, how you should give. That is that is none of our business. We are obstetrician. But yes, prevention, we are the best, right? So our role is in the prevention. So friend, every obstetric unit and every person of the obstetric team must be trained and skilled to manage maternal collapse. There is no time for referral, and referring the woman in this worst condition is detrimental. She may die on the way. So the team should manage effectively then and there only. And for this, we should have an efficient multidisciplinary team, not only SDU, right? So even if you don't have the multidisciplinary team, your every member should be able to at least do the primary or first aid management to revive the patient by the time your team comes and helps you, right? So friends, thank you all of you. I would like to thank all the chief guests and guest of honor for today's program. I would like to thank both the Society Indore President Secretaries, Dr. Sumitra Yadav Madam, Dr. Sunita Chauhan, and of course, Dr. Rakhi Bajpai and Dr. Abha. And I would like to thank all of you, my dear Dr. Dipti, and the speakers, Dr. Sumitra Yadav, all the panelists. I would like to thank all of you excellent inputs from all of you, and I really appreciate your efforts and your way of presentation. Thank you so much, everybody, for gracing the program and, of course, for your valuable inputs. I would just use this opportunity as, to make a humble appeal to all of you that myself, Dr. Sneha Puyar, I'm contesting for Foxy Vice President from West Zone. And if you feel I deserve, please do vote for me. Thank you so much. The voting period is between 1st to 10th August, and for West Zone, you have 2 posts. So please do consider me as one of your, valuable votes for your.
Thank you so much, ma'am, for a wonderful panel discussion and all the very best for this upcoming elections. We are with you, full support.
Thank you, my dear. Thank you so
Thank you so much, ma'am. Thank you so much.
Wonderful session. Wonderful.
We really enjoyed the panel and we learned a lot, ma'am. Thank you so much
Very
for the
nice
opportunity.
cases discussed.
Thank you. Thank you, dear. It was
Thank you so much, ma'am.
Dr. Anuradha down. Yes, yeah. Anuradha, please, last word from you.
Let me congratulate Madam for very interesting cases and congratulate the panelists for a very interactive session. Madam, we learned a lot. ऐसा होता है कि the same topics are
we are
being
learning
presented
today.
over and over again, but there is always one take home from every case. So it was really interesting, and we wish you all the very best for your future endeavors, Madam, and also to Dr. Shweta.
Yes,
And thank you so much. And
I can see Dr. Jyoti Bindal, madam. I don't know whether madam is still there. If at all, we can have madam's opinion. Yeah, definitely. Dr. Dipti, thank you so much. Dr. Paulami, thank you so much, dear, for all the coordination, and thank all of you again. Thank you.
Thank you, Shweta ma'am, for guiding me, and all the best to Dr. Sneha ma'am and Shweta ma'am for the upcoming elections.
Thank you, dear. Thank you so much. Thank you, all of you.
And good night. Good night
Well,
to all.
very well.
Good night. Good
All
night.
the best. Good night.
Bye-bye, ma'am.
Thank you so much. Thank you so much. Bye. Bye. Bye, Dr. Shaji, Dr. Paulami, Palak, Mona, Anuradha, Dr. Sapna. Bye-bye.
Bye-bye. Good
Bye,
night.
everybody. Hello, Madam Sumitra. Yeah, hello. Bye-bye. Thank you so much. Good night. Good night. Good night. Bye-bye.